Good morning. Good morning. Happy Wednesday.
We are going to ask you to follow a couple of things that we did on when we first met. Please, everyone, put your names back into the chat box. Okay, that's one of the unofficial ways we take attendance. We do several things to make sure you're here throughout the whole thing, but so that's important. Okay, great, excellent, excellent, excellent. All right, so great. So while everyone is logging in, we have a certain amount of folks here today. So welcome everyone. Good morning, wherever you are. And if it is good morning over there, it is here on the East Coast. And let's just officially start and just welcome you back to day 2 session of Cultural Humility and Cultural Competence, a journey to improved outcomes. And so one of the things I wanted to kind of just go through is, first of all, you folks had received some homework assignments. And throughout the training, we'll cover different aspects of that assignment. You should have been able to view and reflect on the what we call the Angry Eye video. And we'll certainly discuss that today. We also had 2 handouts, Social Determinants of Health and Covert Racism. We'll discuss that as well today. Now, as far as all of that is concerned, that's what the homework that you had. The reason why it's important to mention is because this whole course will give you 15 hours of continuing education credits according to New York State. And that will be, and those assignments will provide you about 3 hours, all 3 assignments will provide you about 3 hours to add to the 12 hours that you will have when you're visually available here on this platform. All right, so just kind of double check the logistics. It's really important that you be available here. One of the challenges that we have had is to be able to have you present, which is visually present. And I know that's a challenge. We have different ways where we try to assess your availability, your presence here. And it's all because we really invested in making sure that you get, that the time that you have committed to being here, that you have those hours accounted for, and you can use that towards your credentials. This next assignment that you will receive after today's session will include some writing. And so we kind of just, you know, when you participate and share your thoughts about certain things, we kind of know that you've done the assignment. And so working on that honor system, you know, you'll get your 15 hours as long as you stay all the way through to Friday, okay? So the couple of things to go through. So we went through, so you had the handouts. You know how important it is that you sent in whatever assignments we're asking you to send in. And also, and how the accreditation is going to work. One of the things I wanted to ask about is, we've covered quite a bit on day 1. And a lot of it has to do with foundational principles, the definitions of principles, and we started to unpack some components that speak to an environment that requires for us to be more culturally informed. And so are there any questions, thoughts that kind of stand out from what we covered on Monday? Anything that you wanted to share about the previous session?
I would just say, like I did on Monday, it was very informative. I was quite pleased with the content and how it challenged me to think differently.
Okay, very good. Nice job. Very good. Thank you. Yvette?
Yes, you know, I say I'm not biased, I'm not prejudiced. I say this all the time, right? But I am. I'm even biased in my own family. So you've given me some self-awareness with this class to kind of, you know, see it, and I don't have to argue about it. It's just something that happens. It's I don't want to say it's the normal thing because it isn't, but some of us have those biases that are present, and you can see them, and then there's some that we keep hidden. So I've identified that with myself, and the video was really good. The video eye opener, I something.
Uh-huh.
I really enjoyed that video. Yeah. Thank you.
Thanks, Yvette. Hi, Ashley. Good morning.
Hi, good morning. I just wanted to say that for the identity wheel activity that we did, I've actually done that activity a few other times through school, and It was really interesting to do it during this training though, and hear everyone else's reasons why they chose different identities for the ones that they think about often or don't think about often. It just gave me different perspectives as to reasons why people may choose to prioritize some identities over others.
Nice. Very good. That's part of what it was meant to do too. That's great. Thanks. Oscar?
Thank you. The one area that I reflected on between Monday and yesterday was the continuous topics that we threw out on stereotyping. And so when I was at John Jay doing my graduate studies, I had to research a lot of statistics, and they very disturbingly showed in repetitive studies that Blacks and Latinos are at the highest rate of crime. And they also showed that they are at the lowest rate in terms of income and education. And so, because these statistics were repeated uh, in multiple different studies, they become valid in terms of the information that's obtained. So, relevant to stereotyping, I am concerned that the professional arena, and that includes us, will have to continuously look at that. The stereotyping, and when is it real and when is it not real? And because obviously the problem with stereotyping is generalizing it and saying that what applies to patient A applies to person B. And that simply may not be the case. But those statistics that do seem to fuel the negative stereotype, and when they are real, then they have to be looked at. When I say real, I'm simply going by the standards of not obtaining a college education, having incarceration in the past or in the current status, and how that may affect a negative stereotype. And that we as professionals do have to look at that. So that's the area that I am looking at or thinking of at times.
Thank you, Oscar. I think that all that speaks to when Dolores was going over implicit bias and the fact that first of all, we're malleable creatures. We are influenced easily by what we do every day and the environment we live in. And so the continuous part is also a component of cultural humility, which is an approach that we can consider to check in on ourselves every once in a while. So, and one of the highlighted points that Dolores brought up was that we all have it, but we can mitigate the impact of it. And so there are strategies that we can use, but we'd have to commit to it. And the impetus to commitment can be the fact that we can notice certain things about ourselves once we're raising awareness, which is a huge part of the goal and with this training. And so, and if we can see outcomes with the client communities we work with, there's different opportunities to see reasons for us to look at ourselves. And so when we can commit to doing that, we can use certain strategies to mitigate the potential impact of implicit bias within ourselves and also within systems as well in terms of our environment. So thank you for bringing that up. And we're going to discuss some more components that kind of speak to why we have that and why we may have tendencies in certain ways. So thank you for that, Oscar. Christine.
Good morning. I guess excuse me, my voice is a little raspy, excuse me. I guess one thing that struck out was the picture, when you put the pictures up of the different individuals. I think it was two males. No, was it two female, a male, and a female, the picture, if I remember correctly. And same person, different clothing, but that did impress upon me based on just by the outward appearance or the clothing, it brought into my mind, do I do that when I'm walking down the street? Do I do that meeting someone? Do I do that meeting whoever it may be? And sometimes I do. And so I have to be mindful of that. But it also brought me back to my own cultural upbringing of generational cultural assimilation, where parents or grandparents would always come home and you would say, okay, you're home now. You can take off your good clothes and put your other clothes on, put your house clothes on, your play clothes on, or don't walk out this house looking raggedy. I mean, what if you get hit by a bus? You have to look good. And then at the same time, it's like, if I get hit by a bus, I'm not thinking about the clothes that I'm wearing. But it also comes with, I understand what they were saying is, you are in this country, you are of a certain, you cannot look shabby because that's what people will think that you are. And I understand where they were coming from. But seeing that picture reminded me of that. And it also had me thinking not just of current biases and assimilation, but also generational cultural biases. So that's all.
Wow,
Thank you.
Christine, I think your mother knew my mother, or vice versa. Yeah, I think most of our moms probably knew each other. So thank you for sharing. That's a lot of different details and layers that you just spoke to. I love the key thing here. I think that I take away from what you shared was that you became more aware of how those different aspects of you growing up and what you've learned and how you were raised, play a part in how you see things. So I appreciate that. That really is great. Thank you. Good morning, Tracy. Can you unmute? Possibly.
So I have two folks here. One, what Oscar said when he did his graduate studies about, I call it the isms, how me as a Black woman being tall, bald, and long nails, I see how white women treat us and how statistically, when he talked about statistics about crime, statistics is done in a way to isolate Blacks and marginal people, to say that we're not worthy. But when you get into the system and have been a civil service employee, you see that that's not always true. Statistics is done in such a way that it's created a system to make other people look at minorities as if we're not good enough. I want you to understand, historic Black colleges, especially in the South, they're trying to get rid of them quickly. And when they did diversity, they fired 3 Black professors. These were women in the South. This is going on today. Alabama just passed a policy where they get ready to close one of their schools. So they do this, and when I mean they, you have white Anglo-Saxon males who do not want us to accomplish a lot. That's one. 2, what Christine talked about, parents telling you always take off your good clothes. That was done psychologically to embed into us to buy all these designer clothing to make sure that we fit in. And I believe it was done. There's something on YouTube where they show you how when you tell a person of color how good they look in something that costs more money, they'll buy it. I just want you to go back to years ago, 70s, 50s, the 60s, when we tried to get into different jobs, how we were always segregated against that. Statistics are done to keep us oppressed. That's just my opinion, and have seen that. Have watched a lot of my colleagues who are social workers who could not pass that exam because it was designed to make sure we don't pass it. If anyone remember when Bloomberg was in office, it's called the Black Falcons. These are the Black firefighters who fought against that exam where Blacks and Latino could not pass that exam. If you don't remember, up here in the Bronx, going toward McLean, it's highly Irish. Most of the Irish men 30 and 40 years ago came across and they got into the police department. They got into the fire department. Those were the 2 organizations that did not allow a lot of Blacks to come into those jobs. The fire department of New York City is still the only organization that still has 90% whites. So statistically, they do it to design to make sure that we don't accomplish a lot. That's the big thing. Now, I want to leave on this note. For anyone who knows anyone who worked for the school system, all the teachers who were Latino, who were asked to come over here to help the kids learn the language, could never pass that exam. New York City Board of Ed got sued, and those teachers won their case. The test was designed to ensure that they never become teachers. So again, when they do things statistically about us, it's a way to make us feel bad about ourselves and not pursue it. But technically, Blacks and Latino women are the highest educated women. And there is statistics to prove that we are the highest who get educated. And it angers me to see that even in today's society, for those of us who are over 50, and remember when drugs hit the inner city, especially in the 80s, look at the movie New Jack City, and then read Sister Soldier, the coldest winter, how it affected our community. So I decided to go out of our community. Drugs are everywhere. But once it hit our community, oh, just say no to drugs. But when it hit the white, affluent, upper middle class, lower middle class, and the whites, all of a sudden, Oasis changed their name. And now it became an issue where we're trying to help them. So again, I have my own biases about this system.
I appreciate everything that you mentioned, and all of that is documented, and I totally understand that. You know, that's the second time that I hear the Oasis mentioned, and I'm going to speak to that in a second. Statistics, just like anything else, can be biased. I get geeky with research. I love stats. I love research because I've learned how they translate in practice. So once I got to that point, I can see their benefits. But it's not lost on most of us that it starts with a theory, and you can collect enough information out there to make your theory seem relevant or almost conclusive. And so, so it really takes a certain way to kind of look at the data to understand what you can get from it and how it's going to benefit us and how we interact and help the members of the communities that need us, support. And so thank you for mentioning all that. And there have been, and the other things that you were mentioning about the systemic issues and historical events that would continue to happen in this country. This is part of the reason why we're doing what we're doing here now. So this can all come out. Oscar, before I call on you, because these comments are really great and really leading into our content today, keep your hand up. I'll be right back. I really would like to go through how to set this atmosphere so we can continue these conversations and all of us feel safe in doing it. Okay, is that okay with everyone? Okay, all right, great. Culture humility, cultural competence, journey to improve outcomes. This is day 2. So let me just go through a couple of these. So very quickly, I want to reiterate what Dr. Blackwell said to us on day 1, which is this is not a clinical training. Culturally informed or culturally related trainings don't tend to be clinical in nature. It's such a comprehensive array of information and strategies and so on, that it's never been considered clinical, but it's always been considered essential. And so we will, hopefully the goal for us is, part of the goal for us is to increase your awareness, certainly inform you about strategies. We're going to ask you to consider how you can incorporate some of these and realistically within your practice and within your settings. But nobody's ever really culturally competent. No one ever arrives. It's a process. And that's one of the things that we spoke to about it being an ongoing process when I was covering the definitions on day 1. And so, but the idea is it doesn't start unless we start with awareness. So awareness is key. So there'll be unfinished business after this training. The idea here, and this is part of the reason why the original authors in Oasis is really trying to help us understand that it's cultural humility and cultural competence, is that it's really more of a process. It's more about trying to maintain a high level of active use of strategies to be able to be more as effective as you can be in cross-cultural communities. Everybody here is a human being. That means there is no perfection, but there is a high opportunity to try to strive to be as best as you can be within the capacity, within your capacity at your work. So personal truth is also another thing. My colleague and we have our own experiences, our own levels of expertise. We have, I would tell you from my part, I've been doing cultural trainings forever. I cannot do them unless I do research, unless I look at the practices, unless I practice some of this in my own work setting now. Even when I don't do direct services, I always have opportunities in a personal and a professional manner to be able to incorporate some of this. This is an active process. And so we bring our perspectives. We also bring some of the research-based information. We also bring and encourage you to bring in your experience and expertise here, because that's how we're going to understand how best we can apply some of these concepts. So we'll be, again, I tend to talk about the client community unless you want to use another phrase, but clients, consumers, patients, that's really, we're going to use clients synonymously with these other terms, not to disrespect, but to try to be inclusive. But and then we want to make sure that we don't get caught up in politically correct language. So this is a good opportunity to go back to the first day when we first started the training, and every single training that the ATTC does includes a language matters slides. Language matters has to do with using stigma-free language. The reason the language has changed so much, thank goodness, it started with some experts. For decades, we've been seeing disparities, we've been seeing the stigma, and how that is one of the biggest barriers for folks accessing care, whether it's substance use disorder treatment, whether it's mental health, whether it's for other healthcare issues or physical disabilities, for a variety of different reasons. Stigma has always been like one of the top 3 identified barriers in most studies. And so the language matters slides is a good time to also bring it up today to remind us to commit to being more intentional with our words. Because when we use certain words, certain references, we may be speaking in a stigmatic way. And when we're doing stigmatic, and when we're doing using stigmatic references, what it has an opportunity to do is to really alienate folks, because we don't necessarily say things with a motive to offend anyone or to chastise anyone. But some of the terms that we use that we know that maybe we define very specifically can be internalized very negatively in our client community. And so we want to use more recovery-oriented or more supported, more language that is more aligned to supporting the individuals that we're trying to access some kind of quality of care and quality of life. And so our language should be reflective of that. And so that happens. It starts with awareness and a commitment. And it's up to each and every one of us to do that. This happens to be a really wonderful place to start to do that. It's here, this environment, let me go to here, this environment should be a safe space. I always think about how this space really belongs to you folks, you the participants. And this is like a laboratory. While it is a professional day, you're not doing direct services. So that tends to have us kind of relax a little bit. And so we're able to kind of share ideas with each other because our peers are here. And many times, we don't have that opportunity unless we're in a training. And this particular type of training would allow that. And we certainly want to hear about your perspectives. We also want to be mindful about how we hear each other and the different things, not just what we listen to from someone else's perspective, but also when we're speaking, the things that we say that might have an impact on other folks. So there was an opportunity that Dolores had brought up for us to understand that it's very likely that somewhere along the line, because especially during this lengthy training, that there may be some ouch moments, some things that kind of just doesn't jive with you, just it kind of rubs you the wrong way, so to speak. And so this is where it needs to come out. So this is where we build awareness. This is where we can help ourselves to change and commit to, improving upon our dialogue and our perspectives. And so all of this, none of this is forced to anyone here, but it is laying here in front of you so you can take what you need to improve. And so in the outcomes, it's really where you're going to see the results. So let's listen to each other. Let's agree to disagree. It's important that we speak from the I. There is no right or wrong here. This is a place where it should be comfortable enough. If you want to share your work-related experiences or other experiences, feel free. If you don't want to, you're not forced to either. But if you do, there's not supposed to be, there's no judgment here. And so everyone has their own experiences and way of looking at things. And this is the opportunities to help us evolve. And so this is the other aspect of what is said here can stay here, should stay here. That's especially important. There are times where something very important, an important point was made here that you can translate back with your colleagues at work. Attach no names. We practice confidentiality in our work setting. Well, let's do that here as well. No identifying markers. You know, the important thing is that the information is used appropriately to inform your practice and help you to meet the needs of diverse communities and marginalized communities. Everyone agrees to make an effort to contribute honestly, or I don't like that word honestly, but I'll say as transparently as possible, and shared and deal with feelings in a positive fashion. And my colleague and I are very well aware that this can be this can really speak to vulnerability here. And so we are going to be supportive of one another, you know. So the ouch, when the conversation is triggered, when you're feeling overwhelmed, is important. There are things that you can do to take care of yourself in that moment. You can always reach out to us, the trainers. You can also reach out and step away from the mic for a moment. We are going to unpack a lot of the maybe bias-related situations and experiences that tend to come out that is part of what impacts us as providers and impacts what we do with the client community, as well as what impacts client communities themselves. So we want to make sure that this is a safe space. So safe space meaning, let's address the isms here. And so the reality is about, when we think about isms are like, isms really speak to discriminatory or negative beliefs and behaviors. And so it's typically fear-based, you know, it's often, most times it comes from ignorance, it comes, you know, it's stereotypical, you know, references or perspectives, and it really speaks to a lot of ignorance. Ignorance meaning a lack of information, not in a negative way, I'm just thinking in a factual way, where people may not be as informed, and so only work with what they have been influenced by. And remember when Dr. Blackwell was talking about implicit bias, that has a lot to do with it too. And so we want to be mindful and intentional and how we comment and consideration of each other, and understand that we have a space that should have no racism, sexism, ableism, ageism, sexism, xenophobia, homophobia, transphobia, fatphobia, no hate. Pretty much is what we're trying to do here. But let's be comfortable with providing each other space so we can grow here. And so to the best of our ability. And so the ground rules and the isms, just went through it. What we're going to cover today, social determinants of health. We're going to discuss trauma responsiveness through a cultural competence lens, terms of definition, power, and privilege. Now let me come back here. I have promised, okay, so any questions about how we're framing the atmosphere and how we're going forward?
Yeah, I would like to make a comment on what I said about statistics, and I'm going to be brief because obviously this is a huge topic, and it's not just going to be one-sided into one area. So respectfully and briefly, I have a master's degree in forensic psychology that I got from John Jay College of Criminal Justice. Part of that included me studying statistics for about a year and a half, and the training was mainly on how are statistics gathered. So basically, that's where I was coming from. I was not so much overwhelmed by any particular study. It was more how these statistics are repeated nationwide and what the impact of that is. So if it's given to a professional to look at, then the professional, such as you or I, is supposed to be looking at remedies. And what does this mean? So if this shows what it shows, what is the impact of that? And of course, yes, one will question the whole scope of what statistics are we talking about, and who did them, what institution did them, how were they validated, were they repeated by in separate companies, so that you sort of want to factor out favoritism or bias. because if you repeat the study over and over in many different states by different institutions, and you continue to come up with a similar result, then that is in fact how in the industry of statistics they do become valid. So one has to be observant as to whether the studies are repeated, who repeats them, do they allow years to go by before they repeat them again, is it separate companies that are repeating them, and if the information appears to be slanting towards being similar, then there is a problem that has to be looked at. And so that's basically where I'm coming from. I'm totally aware that statistics can be misused and that persons can start quoting statistics all over the place that are not valid just to support some kind of racist view that they may have. But my aim is much more to cure a problem. I worked in this industry for many years. I worked in Rikers Island for 6 years, in the hospital drug and detox and rehab units for more than 20 years. And however, I'm limited to New York area, but within the New York area, I have to say that the overwhelming majority of the clients and patients were, in fact, Latino and Black. And that is something that we do have to look at. Because what happens is that if we do not look at it, that singular issue right there, if we do not look at it, then we are in denial. So we have to be observant of that. Um, it does not mean that we take this data, even if there is some validity to it, and run with it and become, uneducated, racist kinds of persons. That's not what the data is for. It is not saying that one should stereotype and apply it to all, but the numbers are high. So I just wanted to emphasize that. Also, bear in mind, I'm making an I statement here. There's me and the research that I have done relevant to the education that I have had. So I am respecting others who will have totally different views and analysis of statistics, for example. That's it. Thank you.
Thank you, Oscar. Every one thing, every one concept, every one experience, every one issue that we can all come up with can be looked at from an array of different perspectives and used in many different ways. And we just saw that. And that's really important and relevant to what we're going to continue to discuss here. So all points are heard, and we're going to continue on here. Guess what we're going to talk about? Something a little different. Just to lighten things up just a little bit. How about we talk about social determinants of health? Who's heard of that? Thumbs up, thumbs down. Thumbs up. A thumbs down. Oh, some thumbs down. I'm not interested. I figured by now everybody's heard of it. Not that I want to make assumptions, right? So let me ask you folks. Okay, a lot of people have. A lot of people have. From everybody who has. Very good, Tracy. So for everybody who has, does someone would like to take a chance and kind of just explain what your social determinants of health are?
I'll take a stab at it.
Okay, good.
It's the factors. It's the factors that contribute to or really determine our health and well-being, and things like housing, economics, or financial status, social economic status. What are the other ones? Education. Things that contribute to our well-being, or how healthy we can be. So in other words, you can't just look at, okay, a lot of African American people have high blood pressure. What contributes to that? Is it the food and nutrition? Is it the stress of the, their circumstances, their economics, their education level, whether or not they're able to um, speak with that physician and advocate for themselves and get the appropriate medications. So all of these factors contribute to your health and well-being.
Thank you, Teresa. That's a great way to start us off. So social determinants of health. So these are, think about the different life domains. What affects a person's healthy development? So ideally, it's the different aspects that influence his development, those environments where people live and are born, just like Teresa was saying, where people live, where they are born, where they work, where they go to school, where they worship, where they raise their families, all of that. An array of those to different degrees have an impact on healthy development. And so ideally, we want to think about the quality of life outcomes behind these environment, these conditions. And so the framework is really referred to as social determinants of health. I've also heard it referred to as social drivers of health, which is another way of kind of thinking the different environmental factors, as Teresa was speaking to factors, the different aspects of a person's life that influences how they develop, how their health goes, and what influences that in whatever direction it goes. And so we're talking about things, like safe and affordable housing, and Teresa spoke to like the quality education. Ideally, we want to have public safety. We want to make sure we have access to healthy foods, health services, quality health services. Let me put it like that. Many environments free of life-threatening toxins. And so here it's pretty important to understand that when we think about, say, equity, and there's a lot of levels of inequity. Health equity really speaks to making sure that the opportunity to access these different domains, ideal quality domains for someone to grow up or raise a family in a healthy environment, that they have that opportunity. What can be very challenging for most folks can be, especially for the folks that we work with, it can be that the social determinants of health, those different domains are more deficient than ideal. And so we often note, and matter of fact, we've seen this documented for decades, that, that health disparities, have existed, and having to do with race, gender, ethnicity, socioeconomic status, geographical location. They tend to be not just the factors, they're often considered predictors of poor outcomes and associated with deficient areas in social determinants of health. And so in those individual factors, which you can see here, just think about this. Just picture an individual right in a little blue circle, right? And think of that. And then think about the environment and where they grow, they live, they work. I did, every single day, day after day after day after day, years after years. And so while a person is growing, while a person is developing, the influences of the environment has an impact. And so the person's, for certain factors that influences an individual and the health status has to do with their genders, it has to do with the culture and how they do things, age, depending on, age-related issues, their race and ethnicity. Individual behaviors have to do with, is there opportunities? Are there health, are there gyms in the area? Are there public parks where, where wellness is part of the environment, which is a really good thing for your kids and for yourself? Is there good options for eating, or are there deficient options? I mean, there are some areas in New York where we know that it's easier to get to a franchise eatery than it is to get to a health food store. And so what does transportation look like? What's the economic level or financial level for families? So the work environment where they live, the socioeconomic factors, and political factors. So we think about inequality, segregation, social cohesion. These are factors that contribute to a person's current state of health. These factors can be biological, socioeconomical, psychosocial, behavioral or social in nature. One of the things that we want to keep in mind is that because for many of the folks that we work with, they tend to have some of these areas are pretty deficient. And when it's pretty deficient, it increases stress. When it increases stress, it increases the likelihood of having to deal and cope with this. So social determinants of health is also associated with behavioral health issues. And so for instance, the deficient areas, so think about folks who are uninsured. There's about 30 million people right now, uninsured Americans in this country. About half of them are people of color. But when you think about, and a third of them are non-Hispanic white population. And so the burden bears more on people of color, but it's bearing on a lot of folks who are challenging financially. There's also, when I think about social determinants of health, and I think of the 5 boroughs in New York City. Now, I'm a Bronx girl. I see you, Melinda. I'll get to you in a second. I'm a Bronx girl. It's part of the reason why I love to do the work I do. Bronx happens to have the highest rates of asthma and diabetes amongst Black and Hispanic, and I'm going to say Hispanic, Latino, Latinx, Latin. I'll use them interchangeably to be inclusive. But among the Black and Hispanic populations, diabetes and asthma seems to be around more higher in the Bronx more than the other boroughs, and that's amongst the people of color. And so, racial and ethnic groups, people from low income backgrounds, and individuals who live also in rural areas have a harder time of accessing very specific healthcare needs. Their healthcare resources are limited, and a lot of times, say behavioral health issues are more might be addressed through a primary care physician as opposed to a behavioral health resource, because they may not be available or accessible. And so the idea here is to understand that thinking about social determinants of health is pretty important, especially for us folks who are thinking about working with someone around their substance use disorders or their mental health conditions. And so let me just stop the share for a minute and I'll continue on. Yeah, susceptibility to disease and public health outcomes based on socioeconomic status, ethnicity, education level. And here's the thing. Yes, everything here is going to be shared with you folks. You're going to get all these slides. So here's the thing. When you think about this, these dynamics work differently, and it's part of the reality of different people who we work with. And so understanding that is important, even though we may be a treatment provider, even though we may be a medical professional, even though we may be the prevention and recovery support specialists. These are pretty important to understand, because how do you focus on that particular goal of your discipline? How do you help someone with a substance use disorder when their mind is on trying to keep a roof over their head and getting ready to get it dispossessed because financially they're having a hard time trying to pay the bills? And so it's really relevant and important for us to consider how these social determinants of health can be impactful with different people. So I saw some hands up. Any comments, any questions on that so far? Oh, Emelinda, that's right. Emelinda, go ahead. Good morning.
Good morning. I find that one of the things that's often overlooked, because before my present job, I worked for an oncologist, and something as simple as being on a clinical trial, someone of color didn't get that opportunity because they weren't at the right hospital, much less like if they're in a smaller like private practice, they're not getting that opportunity to participate in the clinical trial because they're seen as, well, they're not going to have the means to travel to Texas, they're not going to have the means to travel to California or to Boston, where some of these are held. And it was very aggravating because they weren't even given the option of the ask. And when you turn around and you ask this patient, well, do you know there's a clinical trial? It's like, oh, I wasn't even aware. And meanwhile, someone else who was seen as more affluent, it was really talked about to them about, hey, could you go to Texas and participate in this clinical trial?
Mm-hmm.
And you have to, you end up going out of your way and going, sir, you know what? You have to address this to everyone. You cannot assume that because this person lives in the Bronx or in Brooklyn, in the poor area, that they won't have the cash or opportunity to participate in this trial that could save their life in Texas or California. And that is a disparity that I think isn't addressed as often.
Thank you so much. You remind me of a situation that I had about 10 years ago. How we address hepatitis C kind of just turned the whole medical field upside down. We finally were able to have, medications that were so advanced that we were allowed to say that hepatitis C cured. That's something we had never been allowed to say. We were so focused on HIV, we didn't realize how many people had hepatitis C, and a lot of folks were expiring due to the illness and the lack of information. And then we started to advance the medical technology, and eventually, we really got advanced. That transitional period and just before the advancement of all that made it really hard for people of color to access whatever treatment was available. The treatment that was available, when you think about the interferon that was available at one time, it was only a 50-50 shot if it even was effective. And many times the clinical trials at that time did not include people of color as part of the FDA data that was eventually used to approve the interferon. Bring that up a little bit more. I had a few clients where they had limited income, didn't have their insurance was very limited. So we had to find, when the treatment started to come out, it was really expensive. And that could be a whole other conversation about the pharma world and all that. But the point was that a lot of people in poor places were not able to access that. We had to be strategic, and Melinda just reminded me, we had to be strategic and find clinical trials that may have been in the area, because at that time when it's competitive, all the pharma companies are trying to, hurry up and get a piece of the pie, and they're trying to get some advanced medications. And so we try to have to find clinical trials so someone can actually get a cure, because it wasn't easily accessible to them. This happens over and over and over again. And it takes us as providers to try to be as resourceful as possible. There are the other things. It's like when someone goes in, one of the things that happened more recently in my friend's family, she identifies as Latina as well. Her brother had gone to the doctor. He is a very heavy-set man. And when he had gone to the doctor, he got the diagnosis of diabetes. What was he given? That list of FROMAP, the things, the foods that you can eat and the foods you can't eat. And he came back to her and asked her, what did he do with that? He knows rice and beans, and he knows certain things of his culture. It wasn't culturally appropriate. It wasn't even given him. It wasn't explained what options he may have available. It totally threw him off. And it took a while before he was able to finally get a handle on some kind of diet that can work for him and address his diabetes, because the medical approach did not address his needs culturally, with a cultural lens. And so this is why we're speaking to this. This happens like all the time in different ways. And so social determinants of health has to do, we spoke about health literacy before, and I think I have a slide on that today, but also talk about how the limitations in terms of accessing quality care. And that can be limited for some folks, especially if your insurance allows you to go to certain places, not other places. And now you don't even have too many options, and you have to work with what you got. And that's if you got, because if you think about some rural areas, you don't even have as those options the way in the urban areas you might. And so we can go in different directions with us. And so social determinants of health is important. Why? Because I can't talk to someone about behavior change or any way to support their recovery or wellness process if their issues have a lot to do with financials, if the area where they live in is the same area that is exacerbating their stress, that is actually part of the reason why they're even using substances in the first place. There's a myriad of issues that come up with this that really encourages us to be mindful, be aware, elicit this information, for our different clients. The medical community right now, there are different hospital settings, and there are different medical care FQHCs that are actually health clinics who are actually eliciting information on social determinants of health for their patients. Not everybody knows what to do with them yet. I remember I went to my doctor about a year ago, and I was pleasantly surprised. It was the first time I saw them asking about some social determinants of health with me. The annual paperwork that we have to turn in when we go for physical. And then when I went to see him, when I finally had my consultation with him, what he was telling me, he said, I complimented him. I said, I thought it was great that they were doing that. And he was like beside himself. He says, but I don't know what to do with it. All I know is how to heal people. I said, so you really don't see the connection here? And so I don't want to do a training, but I did leave him with a couple of pointers as to why that would be relevant for treatment recommendations to help that patient for certain situations to increase the likelihood that their outcomes would be more successful with their treatment recommendations if certain surrounding influencing factors are addressed. So I think he's starting to get the hang of it. I think he just at the beginning was a little overwhelming because it's a slight change. It's a slight change or shift in thinking because we're so focused on our goal. Our goal has to be broader, to be more comprehensive and tailored to the individual. And Melinda?
Yeah, no, I wanted to add to that also the fact that there have been so many problems arising from water that is tainted. And the doctors in the complexes where I've worked, they're like, well, we don't have the evidence to prove that this is tied. Meanwhile, people are appearing with cysts, they're appearing with skin rash, they're appearing with breathing problems. But because unfortunately they say I don't have evidence-based data on this, I can't correlate it right away to that. They could have pre-existing conditions that determine this. And I find that that's a bias that we have to address as well. Is that, the doctor may not be open, they might go, oh no, that's not related to the water. Because it's like, but at the same time, these people did not suffer from this according to their lifetimes. They didn't have cysts, they didn't have stomach issues or breathing problems until their water had PFOSs in it, and they were exposed to the PFOSs in the water for over 10, 15 years. And suddenly now they have all these health issues. And it's a concentrated area where they all seem to have had the same well exposure.
Mm-hmm.
Up in the city of Newburgh, all their wells meet from the same water source. And suddenly the city will acknowledge that, oh, we have to connect you to city water. Okay, we have to connect you to the town of Newburgh water because your well is tainted. But then they won't acknowledge the health disparity it's created. And that's like, it's, to me, it's a bias of, well, I need the evidence-based proof. And it's like, well, it's right in front of you. Please start documenting and believing that one could be the other. Like with the Bronx, when they had the incinerator, and that started to cause a lot of health issues. Because right before I moved up here, the incinerator was in my backyard. And then right after that, two friends who they didn't smoke all their life ended up dying of lung cancer. And this to me is a statistic that goes to the wayside. And it's like there's just so much work to do in the area of bias and correlation.
So yeah, it is a lot of help. There's no one specific approach, and thank you for mentioning all that. It's very comprehensive, a comprehensive approach. If we all do our part, and organizations do their part, and we can advocate for systems levels change. It'll keep us busy, but comprehensively or collectively, we can make an impact, I think. Tatiana?
Yes, good morning, everyone. I'm just processing everything, and it's only 10:30, but I feel like I've heard so many great comments and just insight. I just wanted to talking about just like healthcare disparities and stuff like that. It made me think just about like generational traumas and the fact that they don't have advocacy when it comes to health, just because of many different reasons. But one reason that I think I was just like rights. Some people do not know that they have certain rights as just a person in general to access certain healthcare programs and everything like that. And it also made me think about just how in the United States, the women of color are more likely to die from childbirth, just for many different reasons. And it just made me like really think about just how I identify myself and just how thinking about the video that we had to watch on the first day, just how like the percentage of 9 out of 10 lack the necessity to understand like certain medical instructions and just information. And it also made me think of just about how oftentimes families or people who live in like rural places don't have access to like interpreters, so they have to like either research something or just like take their best judgment of it. And like, yeah, it's very, very food for thought, definitely.
Lots of food for thought, isn't it? Yeah. So a lot of the things you mentioned, it really speaks, all those things that you mentioned really helps us to consider, okay, are we doing this? Are we providing that? Because the client community doesn't always know what they're entitled to. And even if they do know, they can't always access. So it's on us. So can we provide the language assistance services? Do we know what the current resources in the area are? Do we have some workarounds? Because it's not always so direct and black and white in terms of like, oh, just give a referral. Sometimes you need a workaround. You have to be a little creative sometimes. And everybody on the platform has the ability to be a little creative within the capacity of what they do, whether you're an administrator, whether you are supervising staff or your direct staff, everyone has the capacity to be creative in how we can access resources for folks. We've had to do that because we have to work with the same inequitable systems that have been in place for decades. So to help meet the needs of a client community. So it does keep us busy. Let me see, Oscar, you were going to add? I'm going to take Oscar and Christine, then I'm going to move on. I don't want to get backed up.
Yeah, just a very quick comment on what I have observed in my work experience with what seems to work relevant to educating patients on healthcare and on health improvements. And that is that a lot of patients receive accurate information from doctors and nurses when they go into a hospital relevant to labs and how they are, what medications should be given, what kind of foods they should eat. They get all those they're pretty consistent from my observation of the hospitals that I've worked in with patients getting that kind of information. Where there is a lacking that I find it to be very significant is when we're working with the patient population of the drug addiction population. That population, because of the fact that they are consuming drugs, their minds are not remembering all the information, housing issues, social issues, and so on. They need information of a different type for them to digest it more and be more connected with it. So what we had in some of the institutions I was with were that we would get, for example, a nutritionist who would come in and do weekly groups, sometimes weekly, sometimes a few days per week, just to give them education on nutrition and on how nutrition is related to health issues and what foods to avoid, what foods to consume, and what can happen when you are not eating correctly and at the same time using street drugs. And the patients seem to have absorbed that more rather than just being told by a doctor or a nurse, well, your potassium level is this or that, and avoid this and take this. It had to be more integrated. You had to have more time to explain it more to them and almost conversationally. And once that was being done, they did become more stimulated and more intrigued and more inquisitive and so on. So I found that depending on how the information is presented, that you can have responses that give a suggestion that the person is learning more. And hopefully, with learning more, they'll apply more of that to themselves.
Well, one of the biggest points that I get from what you said was that how we convey the information. So if it's culturally informed, tailored to how the individual will understand and what is relevant in their life, then it kind of lands a little better. And particularly
Absolutely.
when you think about social determinants of health, how realistic it is if for some of these suggestions that folks get, can they actually achieve it? So all of that is part of the reason why we're talking about this. And I know there's so sometimes when we give information, we kind of just give information, kind of don't necessarily understand. Does the person comprehend? Do they understand what it looks like in their world? Will they be able to just say yes in the office and then go home and actually follow through? Or are they just being kind at the moment? There's a lot of different factors here to consider. And so it's it's how we connect with the individual, use a cultural lens in order to provide the information tailored so they can understand. Christine?
Thank you. I just had, when you were talking about medical, I happen to have an appointment at a physical rehab recently, and PT is rolling by with a particular patient, and they were speaking, complete English. And then I see the person and looking back and forth, and then looking over to a machine, and they're rolling the machine, and everything was 100% translated in Spanish. And I never saw a rolling interpreter machine like that, but it had me thinking how having or understanding culture and having that accessibility when you go to the doctors, when you're in a rehab, that's the most vulnerable place that you can be. So adding not being able to speak whatever language that you have is important, as well as in my case, having that accessibility also for the hearing impaired. It had me thinking about that, how to access more care for people across the board, especially in the medical, when you're talking about different things and how they interact with your health, your mental health, medical conditions, doing the intake with medical stuff. That is, that just pointed out to me the importance of that. And I'm seeing more. Like, I never saw this a couple of years ago. I'm seeing now they have a full course, Spanish medical terminology. I've never seen that before. So now I'm like, what? Now I'm seeing more and more classes like that. So just a comment.
What I'm going to say about that is I think it's great that that's a good attempt to try to be more culturally appropriate. No action is not good. So the fact that they're trying to do that, I think that's great. If it's the right dialect, that's even better. Understanding level of comprehension for the individual and tailoring it better, tailoring it more, even better. So I think those are great. There are different places that are trying to do different things and trying to be more informed and more supportive and recovery oriented in how they support the client communities. One of the things I was going to mention before about OASIS, and because Tracy had brought this up and someone else brought it up in session 1, when the acronym Office of Addiction Services and Support, the OASAS was Office of Substance Abuse, and I forget what the rest was. When the terminology started to change in the field and the stigma was addressed, at least in the DSM-5, part of the opportunity that came up is that the acronym gave OASIS the opportunity to change that and say substance. Office of Addiction Services and Supports, use the same acronym and not have to change and and just kind of revamp the whole organizational reference and title. And even though the CASAC, person holding a CASAC still has, the acronym still stands for Substance Abuse Counselor. And so there are attempts. There is some level of awareness in some places, but it's not just the attempt, it's the follow through. It's what it is that we use. And when we interact, what influences us? What do we do? I talk about substance use all the time, not substance use disorder, because for every person that has a substance use disorder, there's 4 to 6 people that have an unhealthy level of substance misuse that is impacting their health. And it doesn't even meet the criteria of substance use disorder. So it's a broad way of looking at things that can help us to be more specifically supportive for folks. And so that concept, that fundamental concept, is one of the things we build on in all the content that we present here. And I appreciate all your comments. And so let me go back here to social determinants of health and just make sure that we're clear. These are the areas that, because when we have we can think about ourselves, we can think about our client community, we can think about where we work. And many people, the economic stability is where are they employed? Do they have, do they get paid living wages? What about health issues? Can they pay the medical bills? Are they in debt? It's really interesting because education is one of the things that really helps individuals to have better opportunities for different things. And yet these days, education also means, getting into a loan. And we know there are people, there's a term that sometimes I think about, there are people that would be paying their loans for the rest of their life, to get the education and go forward. So it's almost like a catch-22 with sometimes. And so, but in some other areas, economic stability, the neighborhood, what's the housing environment look like? If there's a limited income and you have a family, and this is the best this is the only place you can actually get a roof over the head for your family, and it's not the best living conditions. If heat is challenging during the winter times, if you're in a place like in the Bronx where asthma is more likely to be more part of your children's health or individual's health, depending on the environment that they're in. If there's a lack of playgrounds and wellness is not necessarily part of the environment. So safety, parks, here's that zip code and geography, because there's certain places that is not deemed as very healthy places to live, or only for impoverished communities. Or, do you have education, the quality of education? Do you have food access to healthy foods? Not just every McDonald's, but do you have can you actually get real life fruit and vegetables? Community and social contacts. What is the social support systems? Are discriminatory? Are they high stress? Is there, the violence and the racism that's part of the environment, but also about the system? So the healthcare system, what the coverage, a lot of times the insurance today, depending, and folks who do have insurance, it can be limited. And if they have medical issues or constant, certain health conditions that need to be addressed, the resources that they have to access may not be the best quality. And that's if they can't access them. As I said earlier, how do we provide linguistically and culturally appropriate services? How do we evolve the quality of care? It's these different areas of a person's life that when they're deficient, they speak to mortality, they speak to life expectancy, they speak to overall quality of life and someone's eventual health. And so thinking about social determinants of health, this is a quick picture because I want to turn this over. I wanted to just show you only, when we think about healthcare, that's only 20%. Healthcare only impacts 20% of your overall health. And just remember, behavioral health is part of overall health. And so the health behaviors, whether tobacco use, alcohol use, sexual activity, diet and exercise, and we kind of fall in between those two, but mostly the health behaviors, that's only 30%. So what else is influencing a person's overall health? So you got the 20% of what kind of care or healthcare you can have, 40% of what family support, income levels, quality of education, or if you have different levels of education. The physical environment has 10% influence. So this is what it's speaking to when I meant about we're trying to help folks around their mental health. We're trying to help folks around their substance use disorder. And there are other mitigating factors at play. So we can't just focus on one thing. And so this one kind of shows us a little bit, gives a little more information. When you think about a larger, broader look into taking a step back, when you look at the bottom, both the policies and programs that run the systems that run funding, and think about the physical environment, thinking about and going all the way to the right, air quality, housing, transit. Why I say transit, because we always hear something on the subway. Why are there more police presence in some areas than other areas? Socioeconomic factors, level of employment and education. What's the family social support? What's the community like? Is it safe there? That impacts, so you see policies and programs that speak to the level of inequities or the level of care that are resources that are available and the quality of the resources that might be available, and how those policies and programs kind of speak to health factors and how those health factors result in health impacts. And so when you have a high stress environment, when you have to make sure that you keep food on the table, you keep a roof over your family's head, when you have to keep going to work, when you can't necessarily afford to take a day off because to go to the doctor, unless it's the emergency room because your kids are sick, all of that, what the high stress environments are really speak to how a person or a family may make decisions, whether or not they're going to access care, whether or not they can, whether they can afford it, or what their priorities are. And that's how social determinants of health are influenced by policies and programs and eventually do affect the individual. And so some of the things that we want to consider is how do we talk about determinants of health? You know, the idea here is all Americans, and this is really about equity, all Americans should have the opportunity to make the choices that allow them to live a long, healthy life, regardless of their income, education, or ethnic background. And so your community, your environment shouldn't be hazardous. And then if you have families where they're financially strapped and that's the best that their finances can help them, can we provide other resources? Or how can we help them? Your opportunity for health starts long before you need medical care. So it is these domains of social determinants of health. And so all these other areas are going to impact as well. So achieving health equity is about understanding what creates health. Among cultural groups, what we see with diverse communities, health, the cultural groups, and not just cultural groups, because that's just one dimension of identity. I would say, you know, with racial, ethnic, gender diverse communities, which you tend to see even age-related communities, even the older cohorts have their challenges. What you start to see is that you need a lens to kind of, a cultural lens to kind of start to understand what are the dynamics in an individual's life that's influencing and playing a part and in their substance use disorder, in their mental health. So community capacity for clients to create their own healthy future. Health is not determined by medical care and personal choices only, but mostly by living conditions. We see a lot of housing programs. One of the neatest things that's happened in the last many years is that we have a lot of recovery housing. Well, I say a lot because we never had that before, really. And so we have treatment houses, we have halfway houses, but we didn't have treatment housing. Recovery housing, the way the models are today. And so these are opportunities that we need to expand upon. It's about promoting a well-being in a policy versus health in all policies, beginning with a health in all policy. So approaches that really situates and focuses on health equity as a goal. It's extremely, extremely important. So when you see, you tell me, so I'm gonna need, I've got just a couple more minutes. I'm gonna need 5 volunteers to read this. So health equity means that everyone has a fair and just opportunity to be as healthy as possible. So I would like, under reality, can I have a volunteer to read what's under there? Ashley.
Disparities, disproportionality of poor outcomes, disadvantage.
Thank you. Equality. Yvette.
I'm gonna try to zoom in.
Can you see
Sameness,
it?
giving, yes, sameness, giving everyone the same thing. It only works if everyone is starting from the same place.
Thank you, Yvette. And equity, Angelica.
Access to the same opportunities, we must first ensure equity before we can enjoy equality.
Yeah. Let's see. Brandy, liberation.
Freedom, barriers and limits removed, justice.
Yeah, we're always talking about social justice when it comes to this. Thank you. And Jay Marsha. Inclusion.
Inclusion, access, feel valued, have opportunities to achieve self-defined success and wellness.
Thank you. And now here's the interesting thing about this, and thank you all for your wonderful voices. You know, this is a continuum where we need to continue to get away from what the reality is and push past equality and push back. We're always striving for equity. And if we can go there, it's huge milestone that we can achieve. And if we can get there, then we can get to liberation and inclusion. And this is the type of thing that takes momentum, that takes effort, that takes consistency of energy. Consistency, because this is not an easy place to get to, but collectively we can do that. You know, we want to make sure that in our communities, are we understanding what the disparities are? Can we be able to bridge some gaps and provide opportunities for folks to have access to resources? Can we do the workarounds if that's what we need to do? Even places that, even individuals or families who may not have insurance, what are the resources, what are the opportunities, what are the options? How can we navigate through the system to still make sure that they have quality care and such? And so we have opportunities to work on this, and this is part of the conversation. So let me just say, with the health disparities, these are preventable. Preventable, and the burden of disease tends to fall on marginalized communities. And so it's really about understanding whether it's through racial and ethnic groups, socioeconomic, gender identity, geographic location, people who fall under the poverty level. These are different. These are the communities that tend to have the biggest burden of disparities. And so these are the vulnerable populations, and we just spoke to that. Populations are defined by socioeconomic status, geography, gender, age, disability status, risk status, related to sex, gender, and other populations identified by at-risk health disparities. Think about let's translate this to make it very relevant and relatable for you. Think about the communities you're working with. All this is different information. Where do you see that with the different members that are in your caseload that you have to, that you're doing certain work with? Are we learning what these disparities may look like in their life? Are we aware? Are we assessing for social determinants of health? One of the things that can be helpful is when we see certain challenges with certain clients on our caseload, and some are not necessarily showing when they need to or following through on certain appointments or resources, maybe consider what might be the challenge, what is a barrier for them to actually follow through on certain things they had already committed to. So using this broader lens, it's more of a cultural lens when we start to understand how these different factors can be very specific for different individuals that we work with. And so make this relevant, use this to understand who your people are and how to best support them individually and their families. Your organizations have the capacities to provide an array of different resources, access to them. And so it's us, it really falls on us to help them. And we can help them and support them in them learning how to advocate for themselves and how to navigate through their communities to get their needs met. That is part of what we do. Any comments, any last questions, any last comments? Okay. I'm going to give it to my colleague.
Thank you, Diana. We're now going to transition over from talking about the social determinants of health to really leaning into trauma-informed care and really leaning into that in a very, very thoughtful way. So when we talk about holistic care, right? When we talk about holistic care, when we talk about how we're meeting folks where they are, etc., thinking about trauma-informed care is an incredibly important aspect of that. It impacts every part of who a person is, okay? And so I want to throw out this question and kind of leave you thinking about it, not necessarily to answer it at this particular time, but to really think about it. Pretty much everyone has heard in some capacity about trauma-informed care or trauma-informed work, right? We've heard about it. We have thought about it in regards to practices, etc. How many folks are in spaces and places where they've heard about trauma-informed care? There may have been the integration of trauma-informed care policies and procedures where they are, etc., but the actual practice of it, which is very different than talking about it versus the actual practice. And I kind of want to leave you with that food for thought as we go through some of this material, okay? So I'm going to share my screen. And we're going to talk about this. Hold on one second. Okay. And so what we're going to lean in is to the premise of trauma-informed through a cultural competent lens. Trauma-informed through a cultural competent lens. And that's a little bit different because when we're talking about really leaning into this, we have to look at, one, the impact of multi-generational trauma. The multi-generational impact of trauma. And so when we start leaning into this, we're talking about the premise of historical trauma, which is entirely different than consciously holding on to the past when it resides in your ancestral memory and DNA. And it results in numerous defense mechanisms developmental malfunctions, and behavioral challenges. And this is scientific and is supported in studies. Now, we know that when we talk about the DNA, our DNA is a part of who we are biologically, and that it cannot change. However, the study of epigenetics leans into the premise that our social environment, what happens to us, can in fact change the way that we function. Okay, so we're moving beyond the DNA. Okay, not just leaning into DNA, but epigenetics adds to that conversation and taking us beyond the impact of just the DNA, but how we can be impacted by things that happen to us, happen to our family members, happen multi-generational, across the multi-generational lines. And so it's really leaning into this in a very intensive way. So when we talk about trauma, there's three key concepts that we need to lean into, the 3 E's. So we have individual trauma, which all of us can experience, and it can be an event, right? Or a series of events or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening. And we can also see that. We can experience a traumatic event through visual, and has lasting adverse effects on the individual's functioning, mental, physical, social, economic, and spiritual well-being. So when we talk about trauma, it's not just leaning into the premise of an event. It can be a series of events. And we also need to think about, when we talk about trauma, what may be traumatic for one person may not be traumatic for another person. So folks experience trauma differently. Okay, they experience trauma differently, they perceive it differently. And so part of our responsibility as practitioners, part of our responsibility as folks working with folks, is to get a sense of what they feel or how they define trauma. Okay, what does that look like for them? I like to use this example when I'm talking about trauma, about the concept of safety. In many ways, we use safety as this fairly kind of generalized word. Safety. I want to feel safe. I want my family to feel safe, etc. But when we think about the concept of safety, each of us has a different definition of what safety is. For some people, it's immediately physical safety. For some folks, it's emotional safety. For some folks, it's other forms of what safety looks like to them. So when we're talking about trauma, we're leaning into how folks experience trauma, what is their thoughts around what has happened, right? Or etc., what they experienced. But also when folks initially say, I just want to be safe, I just want to feel safe, etc., what does that mean to them? So that we're operating from a place of where the client is at this particular time, okay? So what we're going to do is we're going to see a short video, and I'm going to stop my share. And we're going to talk about, before we start the video, adverse childhood experiences, okay? Are folks familiar with the ACEs study? Have folks heard of that? Just give me a quick thumbs up if you're familiar with it. And you can use either the reactions or you can just do a thumbs up. Okay, great, great. So the adverse childhood experiences study was a study that was really kind of connected to CDC and Kaiser Permanente. And this was a study from a few years back and has been written about in numerous ways and has been used as a launch pad for multiple other studies looking at the impact of adverse childhood experiences on folk and how it then subsequently represents or manifests itself later on in life. So when we talk about the adverse childhood experiences or the ACEs, right? It's leaning into the premise of not only adverse childhood experiences, but it also looks into climate. It also looks into adverse climate. It also looks into adverse community experiences or events, right? So you have childhood experiences, community experiences, and climate experiences, right? And that all comes together in this particular survey to lean into what someone's ACEs score may be. Now, once we get to that information, right, and thinking about it in a much more expansive manner, right, how does that impact folk that we come in contact with in our care? Okay, how does that impact folk? We may be initially thoughtful around the experience around this particular person is challenged by mental health concerns, may be challenged by trauma, may be challenged by a multiple, other concerns. But really leaning back and talking about what has this person experienced in regards to ACEs is an important aspect of the work that we do. So there are a number of studies out there in regards to ACEs, some of the things that are on the ACEs, such as separation, such as incarceration, divorce, etc. And it leads to an ACEs score. And this ACEs score can inform the impact of these experiences on folks as they mature, right? So this short video that we're going to look at is looking at and thinking about when someone comes in to see us, are we taking everything into consideration? Okay, are we taking everything into consideration? We've talked about the social determinants of health, but are we also really embedding and integrating trauma and trauma-informed care into our work with clients? Okay, so we're just going to take a couple of minutes and review this video, and hopefully that will add an additional component onto this.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer, and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or a packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California, and together we opened a clinic in Bayview Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle, and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, Dr. Burke, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you know, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand, better than we ever have before, how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior, and that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is Wonderful. If you're in a forest and there's a bear.
Okay. So just quickly, what are folks' thoughts about what they saw? On what they heard about the ACEs and adverse childhood experiences? Okay, I see. Yvette, you raise your hand.
Yes, when I was listening and understanding it to a deeper level, I recognized a lot of that trauma happens in my own life, where I'm always the 3F, fight, flight, or freeze. I may freeze in the moment, and I'll share an experience that I had. I was working at a hospital, and I took off one day, and it was the day that the Twin Towers came down, right? And seeing it on the television live affected me as if I was there. That's what he's talking about. That's what she's talking about. Like, I was affected by it, just seeing it on the television. I thought it was a movie they were making at first. I kind of like said, oh, they're making another movie with King Kong, because I remember going there when they were doing that filming. So then the second plane hit, and I saw, actually, when it hit it, the first one I saw the after effect, but the second one, and I said, oh my God. And I felt it in my gut. And I froze for a moment. And then I said, oh, I got to go get my kids. There must be a war. And I ran, got in my car and ran to all the schools, got my kids, went to grandma's house, and we stayed there, and we tried to, only one of my children didn't make it to the house at that moment because there was no train, nothing working, and she had to walk from Manhattan. So it was like, wow. And that trauma has lasted with me for all these years. And I wasn't affected by it personally, you know, and I still feel it. And it's changed a lot of my perspective. Like, I used to drive everywhere. Now I'm very cautious where I say I'm gonna go. Like, I don't take a lot of I won't say I'll drive. I take the back seat, let somebody else drive. And I'm a driver, I have a car. But that trauma has still impacted my life today. And it wasn't personal. It was just, you know, a thing that I saw, and I didn't go to Manhattan for like 3 years behind that.
Mhm. Absolutely. Thank you for sharing that. And you bring us back to the 3 E's, the experienced. And we don't have to directly experience an event to be potentially impacted by it. Okay, it's something that we can see. It's something, when we think about the media and the information that we are exposed to, the information that young people are exposed to, and the desensitization to violence, to any number of things. How is that impacting young brains? And these are the adults of the future. Okay. And for us as adults, how does that impact how we see the world? Depending upon what happens, it can shift our entire worldview and how we present and how we feel safe in the world. Okay. I see that Eunice, you had your hand raised.
Hi, thank you. I want to say, taking the trauma informed and learning about ACEs, I actually said this is college educated information that you're given, and I'm so grateful. But when I learned about ACEs was definitely the first time was when I was going to social work school. And it really just helped me to open up my eyes to each person being unique, being individual. And I had to learn to start where the client was. Although I was there to do, a job like where I'm working at now, and I do assessments. And for clients coming into the shelter, I always just ask like, how are you today? And, what happens is everybody has a different answer because, they come from the intake center to the assessment center, and everything for them is uniquely and different. And I like them to feel comfortable, just beginning where they are. and that to me, I learned about dealing with the person-centered and being strength-based. So that really helped me to like develop engagement with the clients that I'm to feel comfortable. But it's definitely informative, and it gives them the opportunity to just come and speak from where they are. So yeah, thank you.
Thank you. And you mentioned something about climate and environment, which is something that we also need to lean into, is that the very nature of going into a particular environment. So for example, if we do a referral for someone to go into a shelter, right? And we're like, why won't this person go into the shelter? So that they're not residing in a potentially unsafe place. For them, being in the shelter may be traumatic.
Right.
Okay. And so
Yeah.
we need to lean into all of that. So we have the experiences, but we also need to also include the environment and the climate as well as a part of all of this when we're talking about trauma informed.
Yeah. Thank you.
You're welcome. Emerilda?
Yeah, a couple of years back, they did a study in Sweden, and it was on epigenetics, and it's what causes your genes to switch on and off or to change. And the study historically showed that the lifespan of the grandchildren was affected by the grandparents' access to food. For instance, if they had suffered a famine, the children were not suffering a famine. The grandchildren had access to food, but they tended to eat more because their genes had been changed due to the grandparents having dealt with a depression or a famine in their time. And so the chemical epigenetics in the switches that turned on to say, "Oh, I'm full," never really turned on to say, "Oh, I'm full." So it's it could be something as traumatic as let's say neglect or abuse, but could also be as the special on the study was called the ghost in their genes, where obesity, cancer, diabetes, we can trace back to sometimes 4 generations back. And I find that between this and ACEs, we're just kind of almost in the beginning of really learning how our genes are changed and affected and how that plays into, not being knowledgeable enough to address that these are things that are maybe more common globally than just our bias. It's a problem that it's a greater spectrum.
Absolutely. And you also brought up a great point around brain chemistry. And so how does that all connect to what is happening for folks and the potential that they may engage in high risk behaviors? Okay. Let's see if there's someone else who wanted to answer. Just wanted to make sure. Miss anybody? Okay. So I'm just wanted to make sure that I wasn't missing anyone because I thought I saw a couple of hands go up and I wanted to make sure that I didn't miss anyone. So I'm going to move us forward if that's okay. We're talking about trauma. We're talking about the impact on the body. We're talking about the impact on the brain, all of that, and how all of that comes to bear when we're working with the clients that we're seeing day to day. Okay. The origin of personal trauma. Okay. The origin of personal trauma. And we're talking about this on an individual level. Okay. But we can also talk about on a larger community level as well. But when we're talking about the origin of personal trauma, sources estimate that 25 to 75% of abuse or violent trauma survivors develop alcohol misuse issues. Survivors of accidents, illness, or natural disasters have between 10 to 33% higher rates of addiction, and a diagnosis of PTSD increases the risk of developing alcohol misuse. And one of the key things also is to think about male and female sexual abuse survivors experience a higher rate of addiction compared to those who have not survived such abuse. And so thinking about the concept of survival, right? Survival and leaning into, are we that language of survivor versus victim, and kind of leaning into that as well is an important part of also processing trauma with folks as well. So as you can see, there are different things that happen for folks based upon their level or how they've experienced or an event of personal trauma, okay? And there's a lot of research out there focused on particularly on women and females who are incarcerated and the level of trauma that they have experienced directly connected to substance use. So these have major, major implications, okay? So the ACEs puts folks at increased risk for a variety of things, including behavior. So we're talking about lack of physical activity, smoking, alcoholism, drug use, missed work. We have some of the physical and mental health concerns, such as obesity, diabetes, depression, suicide attempts, STDs, heart disease, etc. Many of the things you've heard about in the video that we just saw, that it puts folks at a higher risk. And if you may recall, the doses of the ACEs also has an impact. And this really kind of brings home the dose and the accumulation of the ACEs. And so the higher the ACEs score, the higher the potential challenges that folks will face in regards to health outcomes, mental health, behavioral health, etc. So this is something that we need to lean into on an ongoing basis, okay? And if you ever have an opportunity to take the ACEs study or take the ACEs questionnaire, I would just definitely advise you to take it because it's something that's incredibly informative, and informative not just for you personally, but informative in regards to some of the challenges that folks you may be seeing or experiencing and how it is potentially playing a role in health outcomes, substance use, and mental health. So when we talk about also the ACEs and trauma and social location, this is again is another way to connect adverse childhood experiences and the concept of historical trauma over multi-generational. So when we talk about the concept of families who have multi-generations of substance use, multi-generations of heart disease, multi-generations of mental health, etc., really pulling this all together is really, really helpful, okay? So when we lean into the adverse childhood experiences include, social and emotional cognitive impairment, adaptation of health risk behaviors, etc. And then we connect it to the potential of historical trauma, okay? There are strong connections to be made there. So when we're talking about folks who are marginalized, when we're talking about Indigenous folks, when we're talking about folks of color, BIPOCs, etc., how does historical trauma, how does multi-generational trauma play a role in what's happening for them as they are experiencing substance use, mental health, etc.? So we can also lean into the types or the ways that this plays out. So for example, intergenerational trauma, we can lean into slavery, separation, genocide, oppressive and racist eras, the whole concept of post-traumatic slave syndrome. This is some of the ways that intergenerational trauma plays out. We can talk about maternal trauma, such as, of course, leaning back into the ACEs, but we can also stress response systems, hypothalamic pituitary adrenal HPA axis, okay? Or even the very premise of maternal stress during pregnancy, okay? And the connection to RSA. Also, when we're talking about the ACEs, and again, coming back to and being inclusive of all of that, not just the childhood experiences, but the climate, but also the community. Some of the community effects can include children experience less sleep, affected attention and learning abilities, risk behaviors such as depression and suicide ideation. And we then make the further connection to brain functioning, right? The impact of trauma on the brain. We can talk about repetition compulsion, where folks may, on an unconscious level, put themselves in situations or play out situations of prior trauma, okay? The speechless terror from Bessel van der Kolk, which talks about us feeling trauma in our bodies. So there's an amazing book out there, the Body Keeps Score. If anyone has an opportunity to read that, that is also talking about how our body keeps score, or our body experiences trauma before we may even potentially be able to give words to it. And so it's something that we need to lean into as well. So when we talk about contemporary trauma examples related to race and ethnic context, and this is just related to race and ethnic context, there are so many other ways that this can manifest itself. We could be talking about urban trauma with civilian and social PTSD. We could be talking about separation and incarceration. There are multiple studies and research connected to how incarceration of parents negatively impacts young folk and what happens subsequently as they mature. Police killings, detentions, and arrest. Vicarious trauma, okay? Vicarious trauma connects not just us to us feeling or sensing the trauma of other folks or experiencing that trauma, hearing about that narrative, it's us seeing it as well, okay? All of that is a part of this conversation as well. We're also talking about physical, sexual, psychological, and emotional abuse. We're talking about economic trauma, so food racism, food deserts, wage earning, racism in education, racism in employment, not being able to have appropriate employment or opportunities, access to education, etc. Healthcare and mental health care trauma, disparities in care, and therapists not culturally sensitive. And I think Diana leaned into that a little bit when she talked about social determinants of health and how healthcare and healthcare providers have a responsibility as well. We can talk about legal trauma. So there's glaring disparities located in the justice system for Black and Brown folks compared to white folks in regards to persecution and judgment. And identity trauma is also something we need to lean into, such as voting rights, LGBTQI plus 2S rights, and denial of self. All things that we need to consider. So, breaking the cycle of some of this, culturally competent trauma response approaches. Sorry about that, that's an ambulance coming through. And so breaking the cycle of this means first recognizing and acknowledging that a Black person or a person of color is human. And this is across the board with anyone, that the person who we are working with, the person who we are engaging with is a human being in all aspects. And that creates no differences, okay? This is a person who is a human being. And if I can't relate to that person at any other level, I'm relating to him as a fellow human being. And as a human being, we're taking into consideration everything that encompasses who that human being is, who that person is who is sitting in front of us. And that can include culture, it can include their ancestral and intergenerational history. What were the traumas experienced by the person's immediate forebearers, whether that's the family of origin, a generation back, etc., and what they've experienced, right? What they themselves experience. So we're looking at trauma that they've experienced from birth to their current presentation and really leaning into and asking what are some of the things that happened to folks as far back as you can remember to now, and how have you been affected? In many ways, we start these conversations in a variety of spaces that we find ourselves, but are we really present and do we really listen to what is happening for folks? And then making those connections into how they are currently presenting, okay? Are we connecting that to health outcomes? Are we connecting it to substance use? Are we connecting it to mental health, etc.? Because a person who is sitting in front of us is encompassing of not just one aspect of who they are, the presenting challenge, because that's the first thing that brings folks to us, but all of who they are. And so when we're talking about leaning into how someone presents, we're talking about not just what brought them in the door, but who they are as individuals. And so when we're talking about cultural competent care, that's what we're talking about, leaning into folks as they are, who they are, all of who they are, and connecting that to cultural humility, being able to take a step back and not make assumptions based on potentially our own implicit bias or other things that may come into play to say we know who this person is, or we have a sense of who this person is. It's about having that sense of humility to ask the questions and to truly be present and hear them. So some of this is really kind of connected to, again, leaning into trauma responsive approaches. So we're talking about culturally sensitive, trauma-informed care, okay? Not just the conversation around it, but the actual practice of it. And so when we talk about trauma-informed care, service providers can help traumatize clients by one, recognizing the cultural variations of what trauma looks like for different folks based upon their culture, their own individual experience, etc., and understanding the roles of beliefs that are connected to their experiences, okay? Helping to restore a sense of safety. This goes back to asking folks how, what does safety look like for them? What does safety look like for them so that you're meeting them where they are, okay? Not based upon our own thought of what safety is, okay? And attending to the distress of a client. When we're talking about working with folk, right, there are many activation points that can activate trauma for folk, reactivate trauma for folk. So attending to if a client appears distressed is something that's key. Okay, when we lean into working with folks and asking them around, okay, can you talk to me about what are some of the quote unquote triggers to your substance use, right? Really unpacking that in a way that is comprehensive, okay? And doing some planning around that as well. So a client may initially report or present as being in distress, but also recognizing those activation points that can activate distress and therefore connect to other behaviors as well. We're also working within and through the client and their support structures, right? And recognizing that different folks gather support from a variety of different places and spaces. So being open to those experiences, hearing what those experiences are, who are their supports, and helping them stay connected to supports, but also identifying new supports that they may be able to access along their journey. Okay. So I've talked about a few examples here. What are some other things that we can potentially do as a trauma-informed care service provider? I wanted to open that up for a second and see where people are landing with that. So I'm going to stop my share. Can folks give examples?
I think that also, like, for instance, we're mandated reporters in prevention. So we're taught ACEs. And there was a client where she didn't realize that she was trauma dumping on her child. In other words, she didn't realize that the way that her and her husband got together, her ex-husband got together, uh, he was in his 20s, she was just a teenager, she got pregnant. And all this that she was now sharing with her teenager was giving her teenager stress, which was causing her teenager to use, to use substances. And she's like, she didn't realize. So when you're dealing with ACEs and you're dealing with generational trauma, you can't take a bias of, oh, this parent really messed up. You have to take it as she's also traumatized and she doesn't realize the ACEs and trauma she's been through. So sometimes you have to do that, as I call it, a warm handoff, where, look, this service is for you, and you give her the contact of the therapist, and you need to work on yourself while she's working, and you guys are working together, because it's a mother-daughter situation. And unfortunately, so many people are not informed. They're in that survival mode, and they've been in that survival mode for so long that they don't know how to stop, just sharing their trauma, but also sharing their trauma to their child who's not equipped to help them with it. You understand that it creates a trauma, because and the cultural aspect of the fact that, no, I'm close. I tell my daughter everything in our relationship. I don't understand why she's using. And it's like, honey, because you're sharing everything that was traumatic to you, and she sees it from her lens, and it's causing trauma to her. And it was just, oh my goodness, it was a learning experience, because you then self-reflect on yourself, and we had to discuss it as a group, in the sense of, okay, let's get the both help, because the substance use is it's something that has to be addressed. But if you don't address the generational trauma, it's not going to do anything. It's not going to go further. There's more of a slippage, as we like to see, you slip right back into the habit. So it's moving, and at the same time you're left with so much responsibility in the sense of you want to make sure you cover all the bases, and you just can't. It's so big. And you try your best. That's all you can.
Absolutely, and thank you for that. And I love that you brought up the impact of folks are so potentially maybe so used to surviving, right? That's being so used to being in survival mode, flight or fight or freeze, that it impacts and permeates everything that happens for them. Okay. And also, I survived it, I dealt with it. I can share that with you so that you know better when you go out into the world, but yet not necessarily making those connections that in itself, sharing those experiences can be traumatic. Okay. So thank you for that. I also wanted to add one last piece to that when we talk about those activation points. So let's say, for example, we're working with someone around quote unquote triggers to substance use. And folks are talking about, I would like to decrease, okay, that harm reduction piece, right? When we talk about that, we also have to be trauma informed, because the whole premise of decreasing use may then activate past trauma. Okay, so we need to consider all of that on the table. I saw a couple of hands and I want to make sure. Marcia?
I think also as a trauma-informed practitioner, one of the aspects we also need to incorporate as best as we could is the religious and spiritual practices that are specific to different cultures, different ethnicities. Because there are spiritual and religious practices that are only performed or incorporated into the lives of certain ethnicity. And I think as practitioners, it is important that we address those, or that we learn the impact on how trauma or dealing with trauma may affect the people that we serve. Because sometimes what happens is we go to spiritual or religious practices to help us navigate some of the traumatic experiences that we may have. So as a practitioner, it's important really for us to address those with our clients and understand how they play a role in our clients' lives. It's really important to not just dismiss them or not address them at all. If we are really to incorporate and really help our clients as best as we could, we need to look at those spiritual and religious practices.
Absolutely, absolutely. And I think a few years ago, there was a lot of movement around moving the needle around spirituality and the use of spirituality and connecting it to how folks are interacting on a day-to-day, one of their supports, etc. And I think we're still in that place where we're still trying to figure out spirituality. So I think you're 150% correct. As a trauma-informed service provider, we need to consider all of those different moving pieces, all of what folks connect to as a support to help them survive. We know that there are particular cultures where it is, it's used as a way to get them through. So for example, when we talk about slavery, right? One of the things that helped folks potentially survive slavery was the connection to their spirituality. Okay, their connection to God, their connection to all of that. And so we definitely need to be respectful of that. I think I saw one more person's hand raised, and I want to be respectful of the folks who want to comment. I see a lot of comments in the chat as well.
I think that was me, Yvette.
Sure.
I was just thinking as you were talking, and the lady that was talking before, about when we are trying to service a client and sometimes we disclose certain things traumatic in our life and try to make the connection to give them an open door to share their experiences, what they went through. Sometimes that could backfire, sometimes it could work, but it's like a secondary trauma. It's like it's like what they call like a vicarious, like, now we've added on to their own trauma, something else, and or vice versa. I know that for me, I'm kind of like an open book with when I was doing my clinical work. And, I was able to touch a lot of women that had gone through traumas because I had shared some of the traumas that I went through that may have not been the same, but the effects of it are the same. Okay, or mostly similar, but a lot of them are the same. We all come out with that flight or fight, you know, aspect in life. Like will judge everybody behind that one trauma, and we say, oh, this one's the same way, this one's the same way. I'm not gonna go there. I'm not, and it's about trying to understand and being able to expose, because once you expose it, it kind of loses its strength over you, I feel. And then once you've opened that door, now there's time for healing and the spirituality connection where you can heal the spirit because you've been all this time just in so much pain and so much stuff going on that you couldn't move forward. You could do 2 steps, but you would stay stuck more than moving all the way through. This is my experience with the clients that I've serviced. And, I know that a lot of them, incarceration, men, a lot of things that went on with them. And now they're fathers and they have children and they're doing kind of the same thing all over again. Like you said, it's in the genes. It's in the genes. And sometimes it's not that visible to them, to the person that's going through it. And sometimes somebody telling them on the outside, look at where your choices have taken you. Is that what you want for your children? When are you going to change? When are you going to make the difference and show them that even in spite of everything that we've gone through, we can persevere and we can come back better, than we were. So that's my experience.
Thank you so very much. Thank you for that. I wanted to kind of bring us to a finer point because I know it's almost it should be time for us to take a break. And then I will, Iveta, you still have your hand raised to comment, or did you not lower your hand? No? Okay. So I'm going to go with Oscar, and then I'm going to bring us to a close with this because we have another kind of really robust exercise that we're going to be doing. We're going to be processing the anger eye after our break. Okay. The angry eye. Okay. So Oscar.
Okay, thank you. I just want to make a very quick comment on the genetics. There have been many studies where children or young persons in the same family do not have the drug addiction problem. So the father may have it, the grandfather may have it, one son or daughter may have it, but other siblings do not have it. So we must remember that it's not absolute, the genetic factor. And also, in terms of sometimes counseling those patients or clients that do believe strongly in the genetic theory or science, that itself can become a very significant counseling issue, because sometimes they will be under the belief that because father was, my brother was, my sister was, etc., that they will be also. And that has to be broken through, because it's almost like them feeling that there's no way out, that they're predisposed to it and it's going to occur. And one also has to work on the individuality and the uniqueness of each person. So I always find it challenging when I have done groups, for example, and the topic of genetics comes in, and how fatalistic some patients can be relevant to statistics of genetics. And so I find that it's important to sort of give them that feeling that they have the strength and their own individuality to separate themselves somewhat from the genetic background. That because father did it and mother did it does not mean I have to do it. Change is possible.
Absolutely. Absolutely. Change is possible. And we're evaluating or we're assessing folks based on their individual experience, and we're pulling all of that information in. So because of the multi-generational factor, it does not mean that this person will make those choices. And I think you're 100% correct in tapping into that sense of resiliency, sense of choice, etc. Also, to kind of bring us full circle, while we may, as trauma-informed service providers, feel the need to go to those spaces with the recognition that folks experience a variety of different experiences, whether as young folks, etc., also respecting that folks may not see that as traumatic, or that they may not feel comfortable in sharing that. And so we also need to be cognizant of that as well, right? That we may be going into that space and it's like, I am not absolutely ready to even touch that, and being okay with that too. Okay. So it is absolutely time for us to take a break. And so let's look at 10 minutes and come back. And then we're going to spend some time processing the angry eye video that you were asked to reflect on for your homework for today. And we'll take a look at it and then we'll process it, okay? I am going to drop in the chat some questions for you to consider as you are watching the video, okay? So those are questions for you to consider as you're watching the video. And once we finish the video, I'll ask for some volunteers who feel comfortable in sharing their reflections on what they saw or the reflections that they had the first time they saw it, okay? So just give us a second and then we'll start that process, okay? Thank you. Just a quick check, can folks see the questions that I dropped in the chat? Looks like it.
You folks see any differences here? Do you see any differences here? It's a perfectly logical question, do you? What? Sex. Is sex important to you? Let me put that another way. Is it important to you that you're male?
Yes.
Yes. Why?
I feel strong, powerful.
Your gender is important to you.
Yes.
Do you want to be seen as a male?
Yes.
Yes. Has anybody ever said to you, when I see you, I don't see you male? No. Has anybody ever said to you, when I see you, I don't see you black?
Yes.
Yes. Is your color important to you?
Very important. It is who I am.
It is who you are. People don't deny differences. Accept them, appreciate them, recognize them, and cherish them. They are extremely important.
Some people may say some stupid comments that is gonna heat up the room.
I really don't know what to expect. I just expect a lot of argument about things that we don't necessarily agree on.
You, sit here. Go into that room right there. And stay there until I come for you. I'm trying to get the people who participate in this exercise the opportunity to find out how it feels to be something other than white in this society.
It didn't take very long before intimidation set in and before my buttons were pushed.
Your hand is still up. You still didn't learn anything, did you? Didn't I just say when your hand is up, you are thinking of what you're going to say instead of what's being said? Didn't I just say that?
Yes, you did.
And did you hear that?
Yes, I did.
And did you decide that you were just going to do it your way?
I was
Wait a minute, you were on a roll
yes,
there for
I
a minute.
did.
Yeah, thank you very
yes,
much.
Yes,
Now,
I did.
Now, since you choose to not listen to others, what do you suppose we're going to do where you're concerned?
Not listen to me.
Thank you very much. Every time I do the exercise, there is a point at which I know I have made the point. And we could stop there, but you have to nail it down. And so it goes on longer than some people think it should. But you have to nail it down.
May I finish what I was saying,
No,
please?
because you're still thinking what you're going to say instead of what I'm saying. Now, getting right along.
I heard what you were saying.
You're doing
I
it again.
understand what you were
You're
saying.
doing it again.
I don't care.
You're doing it
because
again.
It's wrong.
You're
and you
doing it again.
Persecuted her for standing
You're
out.
doing it
You
again.
Persecuted him for standing out. The only change that ever happens is when people stand out, and I am sat back.
Martin Luther King Jr. was shot. Are you in any physical danger here? Are you in any physical danger here? Is that girl in any physical danger here? Emmett Till was hanged by his neck after he was beaten almost to death, simply because he made a statement to a white woman. What are you crying about?
Sorry.
What are you crying about?
My feelings were hurt.
How were your feelings hurt?
Just hurt.
Should I feel sorry for her?
I don't expect you to.
These people, they felt like it was somewhat traumatic, and I'm thinking, how is this so traumatic when they weren't cursed, nobody was throwing anything at them, they weren't hit, they were just getting upset over minor stuff that happens to us every day, but they don't realize it.
When am I going to quit? When racists quit. Do I have a job for a lifetime? I'm afraid so.
Every experience you have is an opportunity to see yourself in a new way. And if you close your mind to that, if you say, I didn't learn anything from this experience, and I say, sucks to be you.
Thank you, Clyde. So as I indicated before the video, I put some questions in the chat for us to do some processing. What I'd like for folks is just to take a moment, because I know we had a break, but just take a moment and do some breath work if you feel, just to get yourself centered. But also, I wanted to provide an opportunity that if someone felt that ouch, or they felt activated in some way, that they can feel free to take a step back from this conversation, this point of the conversation, okay? So let's take a moment and just take a breath. Okay. And so as folks are kind of leaning in and thinking about what they saw, either this time or prior to this session, let's reflect on what was seen. And if someone feels comfortable in sharing their reflections, definitely feel free to raise your hand and we will begin. Tracy?
Again, be very careful. I'm not trying to be biased to anyone, nor do I wish to offend anyone. But my personal experience as a woman of color, this is what I've experienced with women when you have to tell them their job and they're in the wrong. And it's how you do it, dignified, but they'll still accuse you of hassling them, complaining about them. You're not sensitive to them. So I've experienced this, and it wasn't an easy pill, but I've learned to tell them that's your feelings, not mine. Here's the facts. This is what's going on. I mean, there were many times I had to justify my job because someone didn't like what I said to them, and they made it an issue. So I had to learn. That's not my issue. This is the problem. This is the issue. Here's the information. You take it however you choose and walk away.
So it sounds like, Tracy, this video was a strong activation point for you. Am I correct in that?
Yes, it was, and it still is, even to this day. Have worked with a woman who's Greek, and I had an issue with the family, and I had dignified by saying, I believe this family may have some issues with people of color. This woman turned around and told me, all Greeks are racist. And I had to look at her and say, I had to critique what I wanted to say. And I had to say, well, I've been to Greece. I didn't meet that, but I understand because it's a lack of ignorance. That's where that came from, honestly. From her, it came from a lack of ignorance and some other issues.
Thank you for sharing. And thank you for sharing that example and just kind of thinking about what this activated for folks, this particular video activated for folks. So thank you. Tatiana?
Yes, I just want to say, Tracy, thank you for sharing that. Something that stood out to me were these two quotes in the video. Are you in any physical danger, or how is this so traumatic to you? It made me think just how like we have our own, like ACEs, for example, how something may have triggered us or made us think of something that has happened to us in our life, and just how oftentimes like when certain members or groups of a group are vocalizing their needs or wants, sometimes they may be perceived as just being an angry woman or just like disrespectful or rude in any way.
Absolutely, absolutely. And that in turn may speak to implicit bias, it may speak to a variety of other things that are happening for them, and that activates that for them. Okay. But definitely thank you for that example. Okay. Yvette?
Yes, yes. I recognize both aspects of that conversation with that young lady, because sometimes a teacher, goes into a classroom, the kids are out of control, disresponsive. They're just not listening to her saying, okay, let's start our class, right? So this woman is teaching us something about how these things happen. The young lady took things very personal, I think. I don't know. I think she took things very personal. She got angry about what was being said because she was treating this one that way, that one this way. They didn't get upset. Why are you taking on their uncomfortability? Do you even know if that's what they felt? Um, sometimes we take on the people that we're trying to service, and we challenge them. And I know because I did that once, and I said the wrong thing. At the moment, that one disruptive person took the whole group hostage, and I came out of the side of my neck with my response. After I had a moment to breathe and have a new saw moment, right? I went back and I apologized to that individual because he wasn't ready. He just wasn't ready. And we go through this every day of our lives. One person can make the difference, or one person can make the whole place a chaotic situation by their responses. And I wrote, the video touched me in ways that I never knew I had existed inside of me. And I realized that I could be that person who gets annoyed, aggravated, disrespectful, disruptive, and then it could flip on the other side because it's happened, and we're human, and we have to acknowledge that. What we need to do, for me, I'm sorry to say for me, I have to take a moment and allow that person to say what they need to say, and then tell them, okay, and then we'll move on with the group. But sometimes it doesn't work because the persons have their issues, have their, traumas, right? And I don't know what they are yet. I'm getting to know them as I develop a relationship with the group setting as well as individual. And that's just for me. As I get to know them on a more deeper level, I get to understand the event, the experience, the effects that it's having in their life.
Thank you. So I'm hearing a lot of things that this video has activated for folk, and thinking about leaning into what they saw, and the content is also a part of this conversation as well. So I definitely am respectful of everyone kind of leaning into what it activated for them, but also let's talk a little bit about what the content was. Okay, thank you. Taryn?
One thing that I kind of like pointed out of that video for me was that one of the individuals, got really upset, stormed out. And I think part of that is because she wasn't feeling like heard or listened to, which is kind of the point of the whole thing. Like there are certain populations that always feel like that. And yeah, it's frustrating, so I think that was something that I pointed out.
Absolutely. And I think that's an amazing point, in that there are certain populations that things happen to, right? And it is traumatizing for one group, but for another group, that's everyday life. And so making sure that we are respectful of both ends of that spectrum is an important part of trauma-informed care. Thurston?
Yeah, so one of the things that stands out for me is that, the Miss Elliott was able to dominate a room and have them feel the domination and control of that room. And they're in controlling their lives and what they can say and how they can move about. And to be controlled in that way was uncomfortable, period. Then on top of that, to be shut down when you wanted to speak out, or you felt that you had the right to speak out, or you felt that it was even your duty, which I think the young woman was feeling. She felt it was her duty to stand up against what was oppressive to her. And then, but her reaction to it was she gave up. She quit on her own response to fighting, which was interesting because when you're oppressed, you don't get a chance to quit. And Black people don't get a chance to quit because the oppression is continuous. It's an onslaught. So it was interesting that she could, get away from it. What I missed in this was that you can't verbalize racism, or you can't share a conversation about it with pain. You have to really live it to know it. So I'm not sure if Elliot is really capable of completing her research without having them live it in a social experience or a social experiment that actually makes them feel oppressed and Black and those things. They're hearing it, but I don't know if they're really living it. So I don't know if it's a successful, I don't know if she's successful. So that's it.
Thank you. And I just wanted to kind of put a point on there before we move to the next person, that when we talk about, while this is particularly kind of framed in the context of racism and oppression, etc., kind of hearkening back to something I mentioned earlier in the training on day one, intersectionality. The whole premise that there are different parts of who we are and what we represent to the world, that it shifts. So if we talk about race, it is one shift. But if we talk about education, if we talk about substance use, if we talk about sexual orientation, etc., we can shift, and those identities and how people respond to us can shift. And so when we talk about intersectionality, we're encompassing all of that. Okay, so are we talking about racism in the angry eye? Yes. But if we were talking about gender in another space, it would be a different context, right? So just kind of adding an additional layer onto this around the premise of intersectionality and how different two or more things can intersect, where folks are being responded to based upon those two things. So it can be gender and race. It could be substance use and race. It could be any of those mixtures of things. So kind of thinking about it from that aspect as well. Melinda?
You just basically said what I was going to say, because Miss Elliott basically did this experiment called the brown eye, blue eye experiment. And she went and basically took a class because she was a teacher when Martin Luther King was killed. So she felt she needed to make her students understand that just the atrocity of racism, but also intersectionality. So she took blue-eyed students and brown-eyed, and she made the brown-eyed. I don't want to flip it, but I might have flipped it. The brown-eyed were the supposedly the more have better rights, could speak out, and the blue-eyed children were supposed to be inferior to the brown-eyed. And then she saw that the blue-eyed that considered inferior turned timid and subservient and isolated themselves, and then the brown-eyed turned arrogant when it came to the case. And then the next day they discussed, how did that make you feel? Because she took with the brown-eyed blue-eyed experiment was intersectionality, that it's not just race. It could be any difference when anyone is oppressed. due to their identity, due to their belief, due to their race. And I mean, she can only cover so much. She hasn't lived it. She's not, for instance, you have Ibram X. Kendi, who wrote Anti-Racist, and it's fantastic book, which I think everyone should bother to read. How to be an anti-racist. And she can only do from her perspective, but it does put an eye into talking about that at any time a class of people their humanity can be taken from them, and they can feel oppressed in different places, in different systems globally. We have a problem here where you have people that are, women as a whole are losing their rights over their own body. You have trans people who are losing their rights and to speak, to defend themselves. So yes, race and ethnicity is in our face on a daily basis. We have to live with it, and I don't think unless you walk with it, you won't understand what it is to fear when you get pulled over. Okay, that it's a oh my goodness, let me turn on the cabin light so he sees my hands. Let me try to calm down. Let me, was I going too fast? Let me appear less threatening. I should have worn my hair in a bun today. It did the stupid thoughts that cross. But that it's not just that. It is also the fact that there are many different parts that experience oppression. Trans people experience oppression. Right now you have, women across the world that, they're going to get arrested or killed or stoned, child rights, sex trafficking. There's different parts of oppression, and that we have to really open the eye to look at it.
Thank you. Thank you so very much. And I also wanted to bring folks, and thank you for sharing, everyone who shared. And for those, there's amazing content happening in the chat. So definitely looking at that content as well, because this is something, again, this is a part of the journey, right? We're going to end this opportunity on Friday with unfinished business, okay? And there are going to be things that continue to need to be processed and unpacked. And so being okay with that is key in all of the information that we're sharing over the next 3 days, okay? So I know that we have some other content that we'd like to share, and I definitely would like to transition it over to my colleague Diana so that her voice and her amplification can be brought back into the room, okay? Thank you.
And thanks to my colleague for leading a very sensitive conversation. And thank you all for being, I like the word that was used the other way, magnanimous in how you all participated and shared your perspectives. And so that really speaks to maybe the safety here and conversations that need to be had. To stop running away from it. I know this politically correct thing that we have to do, and the work that we have to do with our client community, but not to be afraid to kind of bring it up. It's the best way that we can support each other and evolve. And I'm really grateful for all of you. So I'm going to just kind of change the tone a little bit and just simply go through some terms of definition, but it's going to speak very specifically to everything we've been discussing. So I'm going to do my own way of doing it, because I'm also looking at the time to let my colleague know that I'm going to try to kind of breeze through it, kind of. You folks are going to get all these slides. You're going to have more information than we have the opportunity to cover. And so these are really good references for all of you. And all the videos and all that stuff too. So let me go here. So first I'm going to go through a couple of slides. And so let's just define what stereotypes are, and kind of to speak to what we've been talking about, because so many different components can be the basis of where our implicit bias may come in, where different, the influences from our environment or things we've grown up with or we are exposed to consistently influences our thinking. And potentially the words we use and the situations and how we address them and how we behave ourselves, let alone bringing all that together so we can understand impacts on communities that we're trying to serve. And so stereotypes. Stereotypes is a set of beliefs about members of a group and typically represent society's shared beliefs about that group. And often and usually stereotypes, stereotypes used to be really had a bad rap over time. Has gotten a bad rap because initially the stereotype was a word that used to be used in referencing patterns within populations. And then over time, it's been used very negatively. So for instance, an example would be and we've spoken to this, we both have spoken to you folks and mentioned this to you several times about the stigma that is associated with people who have substance use disorders. And so, and this idea that they can't recover from their addiction and that recurrence or relapse is inevitable. And so like, why even bother putting in all that much effort? They will never get any better. All these different ideas tend to be absorbed and can work for lack of appropriate or accurate information. And so because there's science to this, to how this all works. And when people do not have the important, relevant or accurate information, they tend to be influenced by whatever else is kind of hanging around. And we're influenced by, we're talking about the media, we're talking about just, opinions by people with notoriety and the things we come across that are not necessarily coming from credible resources. And so stereotypes are some of the things that can come out when we start using, when we start thinking about, say, thinking of people with different disabilities or different people, marginalized communities, or people who are trans or gender diverse, or folks who are maybe have limited English proficiency, and many times the negative connotations associated that have been associated with these populations and resulting in stereotypes. Prejudice is another word that we're very familiar with, and prejudice is a judgment. It is it's a way of thinking. It's an assumption made to something, to someone or something. But prejudice tends to be, in the context of what we're speaking to, a negative attitude towards a person or group. And that also gets supported by our environment, by our practices, by our information or lack of information, sometimes past experiences, but negative attitudes towards a person or group. So it can be exhibited by the degree of willingness one expresses in engaging in varying interpersonal interactions with persons. Many times what we've learned is, like, if you're not familiar with a particular culture, why not engage in some of the festivities and get involved in communities or expose yourself, to interacting with community members and learning more about them. Many times when we lack that exposure, when we lack that experience of interaction, we are more susceptible to negative associations that we hear. And one of the things I want to make mention when Dr. Blackwell has spoken the other day about bias, we are susceptible to things that we don't hear very much more than what we do process on a conscious level, because we're internalizing bits of information from our environment consistently. And I think that the figure she mentioned was 40 million. Well, guess what? The media, the articles, the wording that some political people and some other people in communities are saying, we absorb that, even if we don't agree with it. And if we're not conscious about that, that can actually influence what we say and what we do. So prejudice can come out, and it may influence whether or not we're going to interact and be more familiar with, say, different cultures, or how we may not. The other one is discrimination, the unjust or prejudicial treatment of different categories of people and things, especially on the grounds of race, age, or sex. I want you to look at that picture, okay? So look at the picture of what it shows, the spoon, and look at the two doors. And so in New York, I'm grateful we have a way to address this issue. Do you have any comments? Anything that kind of comes up for you when you see that picture? Brandy.
Yeah, I would think, because it's kind of like he's a spork. And so he fits in both of them. So in my mind, he would fit in both of them, but will he be looked at as different if he enters either of the two? And so I guess in my mind, just that mindset of I'm having to make a decision because I'm both or I'm in between, it puts you in a different position.
Yeah. Yeah. Thank you for that. Thanks, Brandy. Jacqueline.
I was going to say, I'm wondering if it's necessary to label those doors as fork and spoon, because if they're single use facilities, then it doesn't matter if you're a fork or a spoon. It's a room for whatever purpose the room is. And I think sometimes we segregate things, especially based on gender, when it has no value to do so. And it's actually damaging to people who don't fit a gender stereotype.
Yeah. Yeah. Thank you for that, Jacqueline. What's interesting is what do we know about the has been a constant arm wrestling opportunity for a lot of ignorance and a lot of advocacy at the same time. And it's been this thing about where would a trans person go to for a restroom? And it's like, because traditionally, there's countries that have this binary perspective that has been imposed on all of us. And so many times that conditioning we kind of forget, what, it's more than that. We know that the science has been on it, the psychology has spoken to us. We work with folks in the field and with each other, and we know there's more than that. And yet, systems, organizations, settings may have that binary perspective. Who's it affecting is the individual who we're trying to provide services to. If there's no inclusion, if there's exclusion, then we're creating a harmful environment. Social exclusion, negative social interactions, that is really speaking to the policies and practices that treat people, unfairly. And so when in New York, we do have the laws that state the person will go into the restroom where they identify, where they are comfortable with. But that's not the case everywhere you go in this country. And so the lack of access, the lack of opportunity like that, and the fact that the perceptions, uninformed perceptions, thinking as if gender identity is supposed to be, it's uninformed by the science, because people don't have that information. And then acting on it, forgetting there's a human being there, So it really brings up a lot of different things. So I really appreciate those comments. Allison?
Yeah, I was just gonna say, I think, when I first looked at it, my immediate thought was like, okay, yeah, gender identities. This is something that's like consistently being brought up with like the whole bathroom issue. But then I thought about it and I was like, this also relates to like culture and race. When you have mixed cultures or mixed race, like that's another thing too, is like, so for me, I'm Cuban American. My mom is white, my dad is Cuban. So like, do I identify as white? Do I identify as Cuban? Do I identify as something kind of in between? Like, and like where do I fit in? So I think it can also apply in that way too, if you have mixed identities. So yeah.
I like that you brought up that point. One of the things that we always stress is that we as providers don't want to make assumptions of that. And that's why we want to ask the individuals we work with how they identify. We don't want to make assumptions of that. And that's an inclusive, one inclusive approach. And so, it's not like we have to fit a particular model. It's how we feel and how we identify. So as providers, we should be looking to meet that person where they're at and understand where they're at and respect the differences and perspectives, and including identity by asking them. It's interesting though how that's not as simple as we really wish it could be, right? And Melinda?
Also, we have to, it's like it's not enough to change your mindset. You also have to change the form so that it becomes more welcoming. Often you have in the community people that come in and they don't identify as one thing, or they don't identify as, the boxes are not available for them to identify. So we have to change our forms to include binary, trans, not just male, female. And we also have to, make it more welcoming in the sense of, well, this is an all-inclusive bathroom. We take turns using it. If you don't put the effort forward, then misinformation that creates this, because the misinformation, oh well, isn't you know this just male female biology. It's like, no, there's so much more. We are just at the precipice of gender identity when it comes to science, and there's so much we don't know that we're discovering. And we also have decades of research, and McKinsey reports. And so it's a matter of moving and educating people that won't be attending these things, because there are people, it's great that we're attending these things and we have access to it, but we do have to carry this information then out into the world, because there will be people who are not going to have access to this. The people on a different level who are fighting against the RT. It's simply, it's not enough to just understand the cultural competence. Part of the work of the fact that the journey isn't finished is that we have to take this back out into communities where that misinformation is prevalent, and also that they won't have access.
That's right. Thank you for that. It's really about integrating this in practice, and the more we can normalize this, make this just a standard approach of how we work with folks, the more likely this can spread to other places too, and keep that information going, and that inclusivity support being very evident, and so it can be emulated wherever we go, with other organizations as well. Okay, I got a minute, Oscar. Hi.
Yeah, on the cartoon, I think that it illustrates the dilemma in the country is right now, and where it is that the transgender person stands today, and what dilemma do they have. Also with non-binary. I have worked with non-binary persons that will say, okay, so today I feel female, tomorrow I feel male. And they will switch. They will dress differently on each day. So that little cartoon, especially the little big spoon that looks like something out of Walt Disney, um, he is standing there in a quandary. He doesn't quite know where he fits. Um, can he be male? Can he be female? Can he be both? Where does he go? Um, is there a space for him or her? So I think that that captures the ongoing issues that we have, and it's very complicated. Those issues of transgender. Right now, there's a lot of debate with those that are males that transition into females, and they want to be able to participate in sports with other females. And there's a lot of controversy as to whether they should or should not. And the argumentation appears to be that their physiological bone structure and muscular formations is still biologically male. Um, and that it would be unfair for a transgender male to female to race, for example, with a genetically born female, um, because of the added strength. So these areas will continue to get disputed and debated. It's not going to be just an absolute kind of remedy for all, meaning that uh, the the non-sexual bathroom is very helpful and very good, but it's going to go beyond that. The issue and the question of male and female will continue. I don't really, I sometimes wonder how will that ever be truly resolved. Obviously, it can start to get resolved by not violating civil rights and safeguarding civil rights. But the scientific question, I think, will remain. Um, in other words, because I'm male, if I were to transition into a female, it's not just going to be a question of me putting on a dress. It's going to go a little bit deep, much deeper than that. So I think that that's where the little big spoon is at. He's like at a quandary as to where does he fit. Also, it calls into question: is he there perplexed because of something society has done? After all, who put that spoon and that fork on those doors? Somebody did. And so he's there sort of like wondering, where am I and what do I do?
Well, we've been talking about policies and procedures and systemic perspectives that create inequitable or biased systems that don't work for everyone. Gender identity is fluid. We want to strongly encourage anyone who is interested to sign up for our colleagues' presentation on cultural humility with the LGBTQ community, so we can understand why the conditioned societal binary perspective has excluded many people. And this is the whole thing about discrimination, is that the social exclusion and negative social interactions includes the laws. And there's a lot of legislation that has been taken away, practices that treat people unfairly. And it takes not just a training to get to understand how gender identity, how that develops. It's not a black and white or a static type of perspective. It takes more than that, but it starts to at least explain or give us some kind of fundamental understanding of why systems and many settings right now are not necessarily supportive of persons whose gender identity is diverse and doesn't fit within the binary perspective. Binary perspective has been a conditioned way of doing things in this country, and it has excluded people. That's the whole idea here with the idea behind discrimination. Now, I know I saw a couple of hands up. Thurston, I see your hand up.
Yeah, I'm just trying to understand the binary perspective. So for me, binary is not socially imposed. It is scientific. The concept of male and female comes from science. It's not something that man created himself. It's something that just exists genetically in the Gattaca strain. Now, out of that, anybody can then work in whatever, I guess, gender or identity they feel natural in, or they feel comfortable in, or they feel that fits you. I'm sure that people can make that decision, but I don't know if society is imposing a binary system as opposed to living inside what they see as a binary system.
Well, actually, when you think about it, how long have we been seeing male and female restrooms? We haven't been seeing male, female, and transgender restrooms. That has been more of something of recent, but it hasn't been the traditional. Binary in terms of physical, the biological makeup is one thing. Gender identity is more fluid than just two ways of looking at it. And that's why I suggest about us actually going to get more information about this, because many times the confusion comes in between thinking that what your biological makeup is what dictates your gender identity, and they don't. And so, but more understanding of this can be encouraged for everybody if you kind of just go through one of those trainings to get some more. But the idea here is that some people are being excluded. Some people who don't necessarily fit the traditional norm, or and that's the idea behind the discrimination. Jacqueline?
So I think, first of all, we're conflating two different terms. Gender and sex are two different, completely different things. And even sex is not binary. If you've ever met someone with red hair, there's more likelihood that you have met someone who is intersex, whose chromosomes and genitalia are different. So even if we're going to talk about sex, it's not just male and female. There are myriad people who are intersex. Gender is an imposed concept, along with gender roles, that was brought here by the colonizers. In indigenous cultures, there was more than two genders, and people who either identified as one or both, or were fluid between, were not just accepted, they were revered. And that's pretty much across the Americas. And it's a relatively new concept that there are only two genders, because in Jewish religious texts going back over 2,000 years, there are up to 6 genders mentioned. So right now, this is a very difficult time for the LGBTQ community.
Right.
The number of legislations that have been brought up in this country in the past 5 years that choose to limit or discriminate against LGBTQ people has gone up more than 1,000%. And I'm going to drop some options in the chat if folks want to learn more about this, because folks in the LGBTQ community are at a much higher stress level, especially our youth. And as a result, we are far more likely to end up with a substance use disorder.
Yeah. The rates of disparity seems much higher amongst trans and gender diverse than it is even with folks with substance use disorder, with just from a racial and ethnic perspective. So thank you for that. And more information can be had, can be accessed. And I'm also going to include our colleagues' upcoming training as well. And so, so that way there's more information for us to kind of consider. And so this is all kind of coming together and speaking to, you know, sometimes you got to put things where they lie. When you have information, you don't have information, what happens is when we're thinking about racism and oppression, we think about how it can be overt and how can it be covert. And so some things are very observable. Some things are very much observed. Like you can see the restroom doors having one or another option, only two options when another one can be one supported of the sport. Right. So when it's overt racism, we're talking about something that is obvious to us. When it's not a secret, it's not hidden. Covert may be secret, hidden, but you may still see the results of that. And oppressive practices and systems that limit access or limit quality resources to some communities. And so you could be overt or covert. Now, I said this to you folks, and I'm looking at the time, and I know we're like really behind. So I'm going to do a quick review. I'm going to ask you, if you looked at this handout, overt racism, which is socially unacceptable, covert racism, which is socially acceptable. It's interesting the way this is worded, because you have all these examples that go under either one of these categories, you know. And so how many times have we seen this in our lifetime? Whether it's in our work, in our community, in our families, in our, you know, in our social circle, maybe in ourselves. So whether it's overt or covert, if you want, please put we ask you to reflect on this as part of the assignment. What I'm going to ask you to do is put whatever comments you have in the chat box, because this is going to segue to one more activity that I want to do with you folks before I turn it back over to my colleague. I had asked 3 people to volunteer, so I know Val told you to read. Can I have three hands up, please? So I need 3 volunteers. I'm going to bring up a slide. I'm going to bring up some pictures. There's going to be some wording that these individuals will have in their hands. As I bring them up one by one, I'm going to ask someone to read and try to read it exactly the way it seemed to have been said to them. Are we clear on that? Okay, can I get a volunteer to start us off? A matter of fact, okay, and Melinda, you start off. That's great. So let me just show the slide. Yeah, those phrases, yeah, this is something to look at with this handout. And we're gonna kind of bring that into the rest of the content and the content on Friday. So, and Melinda, please read what I believe what you see here. It was, hopefully you can see it clearly. You say it the way you think it was meant.
Okay. You're not like other Black people I know. You speak so well.
Thank you. Thank you for that. I need another volunteer for the next one. Sheree, go ahead.
You don't speak Spanish?
Thank you. Sarah.
Dude, I totally forgot you were gay when we played ball earlier.
Thank you. And thank you, volunteers, for doing this one for you wonderful readers. Now see these pictures, hear what was said to them. These are not made up. This is actual comments that these individuals received. What are these? What can you name these to? What do we call these?
Oh, microaggressions.
Thank you. And so here's the idea, is that with microaggressions, it's really what microaggressions are slights, insults, whether it's intentional, unintentional, you know, and stereotypical phrases, racial slurs, you know, references that are unkind. And many times this is done not intentionally. Sometimes there are times where it is done with intention. There are other times it's done with without an intention to offend, but certainly with lacking information or misunderstanding that they may be offending someone. And so when you see these are, you know, it becomes it's a problem when folks experience this on a regular basis. When people experience this on a regular basis, just imagine the stress that tends to come up for them and having to deal with that. You know, if there were situations like this, I think anybody could speak to any one isolated incident where someone may have been impacted, maybe by a biased comment or situation. But when you have folks, particularly folks from diverse backgrounds, having these experiences more often than not, what do you think it helps? How do you think this can be impactful to them? It affects others who hear it as well. But you know what's interesting? There are typically these comments often are being said, and it's not so much the intention, and I think this is just reinforcing what I said on Monday, is we have a way of reinforcing our biases, and our biases come out in stereotypical language and microaggressions like these. And so it's not like these people are necessarily doing this intentionally, but it has an impact on that individual. And particularly if these folks from diverse backgrounds are consistently hearing this or experiencing this kind of interactions, it can have an impact on them. It builds this susceptibility for increased stress, and certainly increases propensity to try to cope and deal, and not always in a healthy way. A lot of times these can be part of what's going on with the individual's life and might be part of why they're even using substances or exacerbated mental health issues. And so here's the thing is, can we see where we might be as providers sharing our own biases? When we talked about earlier about the language matters slide in the first session, and we brought it up again today, is sometimes the words we use, the references to populations we use, can be really impactful. Think about how, say, let me just get out of here for a second. Think about, say, how the client community has heard some of this and how it may impact them. And we may not mean to offend anyone, but we may be using a word that's commonly used or a reference commonly used, and we might be affecting someone's well-being. Think about how the derogatory terms that we've heard used for people who use substances or people who have substance use disorders. What are some of those derogatory terms? You can put in the chat box. And there's still many of them are still used today. And I'm hoping that everybody's this is not for us to personalize and absorb. This is just kind of the reality of our atmosphere and what affects our clients. Yeah, crackhead, junkies, alcoholics, users, Ed Flacco. Thank you for that last one. Now, what about derogatory terms that are used that our client community has heard, that we've heard other people use also, towards people of diverse backgrounds? What are some of the names like that? Okay, so we got nigger, and we have another term is, and I'll tell you that because I identify as Latina, and spics. Then you start to, and you hear these sipperhead, hear these other terminology. See, here's the thing about that. And speaking back to what was covered with implicit bias and microaggression, stereotypical thinking, uninformed perspectives, is thinking about how everything is intersecting. I really want to use the word that Dolores has mentioned is that the intersectionality of negative associations, how it reinforces other concepts and influences the words we use and influences the things we do or don't do with the different people we provide services to, and understanding what that looks like for us. I was in a committee meeting recently, and we're all talking. We're all in the behavioral health field, and I couldn't help but kind of feel an ouch moment when I heard someone say, "Well, I work with addicts all day," and I was like, "We're working with people with substance use disorders. I work with addicts all day." And see, here's the thing: is the words we use is reinforcing our thinking, whether it's conscious or not. It's reinforcing it. And that influences our behavior. So when we don't understand about the potential influences of the environment and what we know and don't know, and how that influences our implicit bias and how that can come up in stereotypical dialogue, in microaggressions, guess who's getting impacted the most? Our client community. And so when we have a problem with trying to get transparency from them, when we're trying to do all these evaluations when they first come into treatment, when they don't have the capacity to be more than what they can be at that moment, when they hearing these words that are antisocial and antagonistic and oppressive and discriminatory, it puts people in a place where they're not likely to be as responsive to us. That's why we always stressing different components so we can be more culturally informed as we go forward. And so these environments and microaggressions tend to come out, whether it's intentional or not. It's the impact on the client community that we're talking about here. Actually, and many of us as providers can also, we're individuals in the community too, we can also probably understand and probably have our own experiences in terms of how this impacts us. So translate that into how it might impact the individuals that you're trying to provide services to, and how robust your approach can be using a cultural competent lens to help address them. So I'm just going to, let me see, I'm going to just go back and just leave this alone for now. I'm going to bypass, there's a bunch of slides here that you will get, and we will speak to microaggressions more specifically. As the content goes on, everything is intersecting. And so there are different things that we say, different things that we do that are very derogatory. Calling people outside their names, calling populations outside their names. Sometimes it comes in how we are with each other. Do we minimize this person's word? Do they have the capacity to, or the flexibility to do certain things within their capacity without somebody stepping in and telling them what to do? So we see in our work, we see it with our client community, we see in our personal world, we see it in so many different ways. This is part of the reality that many of our clients live with. So one, we're going to say Khadijah, and then I'm going to turn it over. Hi.
Hello, how are you? Good day. I had to deal with something the other day that really caught me off of guard. I mean, I'm a native New Yorker, but I recently moved to San Antonio, I guess about a year and a half ago, because I'm 70 now. So, yay, I'm a retired nurse. So I'm Muslim, okay? And usually go to the mosque at night. Now, what I heard, what the confrontation was about the poor woman, now I don't know if she's a poor woman or not, that was sitting on the curb with a child and another child, okay, about 12 years old, was a Muslima come out of the mosque and say, you people, you get out of here. What are you doing here? If you come here, you're going to make it look bad for us. What I saw were two white women intervening. I know that they were not white, they were only white in color, and it really bothered me because not only just was she talking to her that she was a woman, but it was the way she was talking to her, like she was a piece of trash, and I guess even now, that's emotional for me because you don't talk to people like that. You understand me? You don't talk to people like that, man. You understand? And I said it to her. I said, man, why are you talking to her like that? She said, you get out of here and don't come back anymore. She said, somebody let her in the mosque to have a plate. I don't have anything to do with that. The thing of it is that there's a way to say something to anybody. There's a way to say it. And I said, You know, I said, what kind of people are you talking about? What kind of people is she? She has a, you know, a hijab on, her hair is wrapped. She has a small baby in her arms, another one about 12 years old. She said, those people, I'm a nurse practitioner and I deal with those kind of people every day. And that's all they do is come around and beg for money and come from their country and ask for money. And I said, so she's what? She said, she's from Afghanistan. I said, so where the hell are you from? So she says, Lebanon. And I'm like, really? I'm like, are you joking? You know, she's a female. She's from another country. You're from another country. How long have you been here? She says 13 years. And I couldn't believe that her aggression towards and her anger towards this woman, you know, was just so profound. I just had to say something. I'm not going to keep my mouth shut because that's just me. Between the New York and the West Indian and me, I am not going to keep my mouth shut. So the poor woman got up and she walked away with her child down the street or something. Maybe she's wrong. But in New York, we're used to hustling, you know? So I said, she was just doing a little hustle, man, you know, to get a couple of dollars, you know? That's all, you know? And but just her whole attitude, that's all I really wanted to say. It was just, you just don't talk. And them, I said, you know, your terms that you're using, those people, them, you know, what is that saying, man? Somebody speak to you like that, you know? So I'll be quiet.
Thank
Sorry.
you, Khadija. I really appreciate everyone sharing. These are the realities that we live with and the environment we live in. And for some of my clients, for some of our clients, it's so impactful to have to constantly be at high stress mode, having to deal and cope with this. It's not the easiest thing to come back from. One incident, let alone several or many over time. You know, and so I'm gonna give it back to my colleague so she can go over. I'm gonna give it Yvette, you can share, and then I'm gonna let Dolores kind of just process.
Yeah, thank you. You know what really bothers me? When it's in the own culture, the own race, and you hear these comments about the same people, when you look in the mirror, is you. Like I piggyback on what the young lady said before. Like I've seen that so much, and there's some words that are used in our youth today that's, you know, resonates. The wrong word to be used is the N word, because all the kids are using it. Like it's a, you know, it's like a hey pal. Where did this world change? Like how did this happen? It really hurts me to hear people talk to each other that way, especially when they're from the same culture and they even challenge the other person who's from the same culture, the same race, and they talk to them like they're from another world, like they're an alien from outer space, and they treat them so badly. That really bothers me. So I understand the young lady that said what she said. Because I have a multicultural family. So anywhere, anytime you say something, it can impact me because that's who I am. I'm the United Nations. You know?
Thank you so very much for all the amazing comments. And again, remembering that this is all going to be unfinished business, right? There's going to be unfinished business that we're going to need to attend to after this. So there's amazing comments happening in the chat, so definitely check into that. But it also brings us to a really important kind of point for us to make for today around the concepts of power and privilege, right? So we're making the connections between language, how we speak to folks, how we acknowledge folks, the intersectionality of the different parts of whom a person is, how that can be, you can be the oppressor in one space and the oppressed in another. Okay, while we are focusing quite a bit on race, this can happen in a variety of different ways. And so when we lean into that premise, what are we leaning? What's the core of that? One of those cores is power and privilege. Power and privilege. So I'm going to talk us through a little bit here, and I understand we're definitely close to time, so I'm going to share some of this. And so as we talk about power and privilege, right? Can folks see my screen? I just want to check in.
Yes.
Okay, awesome. So power, what is it? In social science and politics, power is the ability to influence and outright control the behavior of people. And the term authority is often used for power perceived as legitimate by the social structure. Okay, and so the ability to oppose one's will on others, even if those others resist in some way, to decide who has access to resources, right? That's something that we need to be cognizant of in regards to our work with clients. Power is domination, control, and therefore a very selective form of truth, which is a lie. Okay. And so there are different types of power. There's positional power, expert power, influential power, the power to influence others, obstructive power, the power to put barriers in the way, personal power, collective power, institutional power, cultural power, and personal power. That's our power from within. And power, again, comes back to domination and control. And how do we glean from that? Okay. So when we talk about the concept of power and then related to privilege, right? Privilege is an unearned right, advantage, or immunity granted to or enjoyed beyond the common advantages of others. And so an exemption in many certain cases from burdens or liabilities, and those with privilege rarely understand its full impact on those who don't have that privilege. And so when we look at this particular diagram, this particular picture, you're seeing something here that it really emits a powerful image of privilege, power and privilege connecting the two, okay? You see that both folks are running the same race, right? But are they really running the same race? Or is there more barriers being placed in the way of one person versus another? When we talk about the whole premise of power and privilege, every single one of us in this learning space today, that switches out. So when we talk about privilege, we may be privileged in one space, and in another space, we are not. Okay. So thinking about power and privilege and how that's all connected is incredibly, incredibly important. Okay. As providers, you have privilege because you have a job, all right? And you have resources, and you can determine who receives those resources. So that's power and that's privilege. Okay, so we want to connect all of those moving pieces as we continue to process this. Okay, privilege can be education, privilege can be housing, all of those things. And so I'm going to talk about an example really quickly before I move with the last few slides. In my building, I'm going to stop my share for a second. Let me stop my share. In my building, there are two ladies who are struggling with housing, right? In my building, they come in each evening and they sit in the vestibule, or they stand in the vestibule. And what I subsequently found out is that they used to live in the building, but they were evicted. Okay, they were evicted, but this is potentially a safe space for them. Okay, I once stepped outside of my my apartment and stepped in the hallway, and I saw a gentleman talking to them, and I'm like, okay, I really didn't hear the gist of the conversation. But while we were standing at the elevator, he comes over and he says, you know what? I had to tell them that they shouldn't be here. Okay, I'm a concerned citizen. And I had to tell her I was going to call ACS on her and that she shouldn't be here smelling up the building or the vestibule. And they just shouldn't be here. And I looked at him, and what was really powerful was, I think someone mentioned it earlier, when it's someone from the same group who can potentially do these things. That's one. But also the power and the privilege of having housing, right? The privilege of having housing, and how it was all construed to threaten these two women, right? That he felt he had the power and he had the privilege to go and threaten to contact ACS. and how they should take care of their personal hygiene and all of these different things that he was saying to them, right? This is how we need to be aware of how we're presenting to clients, right? We have a lot of power, whether we choose to acknowledge it or not. And I'd like for everyone to kind of think about that and reflect on it. Not necessarily, of course, we won't get an opportunity to go into it today, but to reflect on it. There is a natural power dynamic that is in the room. It is an imbalance of power, because when anyone comes to us vulnerable, asking for help, that in turn may lead to feelings of powerlessness. I have to do what this person says that I have to do because I want the resources. Okay, so we need to acknowledge that that is always in our interaction with clients, whether we choose to say anything about it or not. And so when we are interacting with folks, being aware of what it takes for folks to be vulnerable, to ask for help, what that means for them, the impact of culture, the impact of all of this in our work with clients, okay? So just wanted to leave you with that little example before I go through the next few slides. And every time I see them, I'm like, how are you doing? You doing okay? Do you need anything? And that's it, okay? But the fact that this gentleman felt that it was okay for him to go and threaten them in such a way because of his imagined privilege was very, very, it was sad. And I got quite angry about it as well, okay? So let me just share my screen and share the last little bit that we have here. And we are definitely winding down, folks. Power and privilege, making the connection. Having privileges is not always a negative thing. And privileges should not be taken away, but shared with all members of society. And so when only certain members of society enjoy privileges, it creates inequities, right? So that certain members of society enjoy those privileges, it creates inequities. And once all members of society enjoy the same privilege, it's no longer a privilege, it's gone. Like everybody has it. It becomes an equal right for all members of society. And so membership in multiple privilege groups can result in additional invisible privileges. And that brings us back to intersectionality, right? What might be a space or a opportunity or a challenge around from an oppressed space or oppressed population is a privilege in another. Okay, and that's why we need to connect all of that into the premise of intersectionality and power and privilege. Okay, so also continuing to make the connections, cultural groups experience different levels of power and privilege. Okay, and members of our society with the most privileges tend to have the most power. Okay. And power and privilege are a part of the complex relationship between ourselves, our organizations, and our clients. Okay? It's there. And so we cannot deny that it's there. Okay? So I want to leave us with final thoughts. Okay? Give space for that. And again, this is beginning to unpack this with the understanding that there will be unfinished business. And so leaving you with that power and privilege, leaving you with that little story, leaving you with the thoughts of, regardless as to whether you choose to acknowledge it or not, there is a power imbalance in your relationship with your clients, and how you respond to that is cultural competency with cultural humility to find out their experiences and to hear their experiences and be a witness to them. What are some folks' thoughts about this?
Hi, I just want to say something.
Sure, go ahead.
Okay, thank you. On the issue of the example that you gave about the tenant who made the comments on the two women, Just my sheer singular comment is that obviously he is lacking in empathy. When I went to work in Rikers Island many years back, one of the trainings that we had from NDRI was obviously on how to work with the prison population. But one of the things that always stayed within me was that they said, remember that the scales are not even. You're going home at the end of the day, they are not. Um, there, but for the grace of God go I. That could be you. What if whatever so-called privilege you may have had that made you be a law-abiding citizen and not be incarcerated, what if that had been lacking in your life? What if that was you? So I think that when you said that story, that reminded me of that. Because what if that man also one day finds himself like those two women, unstable housing, undomiciled, or what if he can somehow not even be there one day, but just empathically think about the conditions that they're living in, and how privileged is he indeed to not be living like that? And doesn't that inspire him to be more empathic? So I just wanted to share your story. Thank you for saying that because it was very touching.
Thank you. Thank you. Other folk, I just want to create the, we still have a couple more minutes, so definitely folks can definitely feel free to comment. And Melinda?
I just wanted to, I think it's so important that we have to constantly be aware of ourselves, where we're coming from. Also, when someone is questioning something of us. Because in some cases, if, for example, we went to a place and we were parked because we were trying to get our map and get centering. And we saw this person coming over, and it was a matter of, it's like, what are you guys doing here? Instead of asking, do you need help? Are you lost? Basically, what are you guys doing here? And it was like, you have to then reflect that this person is coming from, their perspective. They don't have empathy, but if you escalate it could be a very bad situation on both sides. In the same time, this person, they're not the road police. They're just a person. And so it's a matter of, we basically address, in this current political climate, it's kind of odd that you would come to a car with two women in it and ask us what we're doing here. Okay. And I know, and it was an older gentleman, and basically, we go, we check our maps on our phones, so maybe it's not obvious to you because there's not a fold out map, but we're checking to see if we got misdirected somehow because, oh surprise, Google was wrong. But it's that privilege of, I feel the right to come to this car where two women are looking at something and go, what are you doing here? Instead of saying, excuse me, ladies, I'm sorry, I don't mean to scare you. Are you in need of assistance? And it's that constant battle of safety and, is this person being a threat? Is this person coming from a point of privilege? Or, am I being oversensitive? Yeah.
Thank you for that. And I'm seeing some great comments in the chat as well. So I think we have time for one more closing comment. And who would like to take us home for today? Okay. I am actually going to take us home because it is 1:27. And thank you so very much. This group continues to be such an amazing group in regards to interaction, talking to each other, talking, just kind of interacting with this material. It sounds as if folks are really processing it and really reflecting on it, which is also amazing. Also, the amazing conversation in the chat and responding to you in the chat is also incredibly important. And it really kind of lends itself to what we talked about the first day. All of this is a learning space. all of this may lead to other unfinished business, that this is not the end all be all, that you won't be culturally competent at the end of this, but that you continue the challenging journey ahead. And so we're going to continue the challenging journey ahead with part 3. And part 3 will start on Friday at 9:30 a.m. and we'll go to 1:30. I think the pre-assignments were sent out for part 3, so you should be checking your email for that, and you'll receive that, and you'll receive all of the information as well. Also, another thing to mention is that if you have any questions or any feedback that after you process the material that you'd like to share with us, please feel free to send us an email so that we can kind of take that in and, really, cater or tailor the training to really meet the needs of everyone who's here involved. Thank you so very much for
May I
participating.
add something?
Yes, Diana.
Hi. You've been so great, getting folks to speak out on this, and you folks have been very candid and have allowed yourself to be part of this as an experience, not just adding. I want to remind us all that everything that we're covering here is all about helping us to try to understand the individuals we're working with.
Mm-hmm.
It's about them. If this helps you with you, that's great, but that's not the goal. The goal is to understand what's happening with our client community so we don't have to agree, disagree, understand absolutely everything, have an opinion. That's not problem. Just understand the different dynamics that's happening with them so we can meet them where they're at, so we can best support them in their recovery wellness process. So I know this has been heavy because sometimes it challenges us personally. Well, we want to thank you for being and staying with us and stuff. And do yourself a favor and just debrief today. And just take that moment to, I think Dr. Blackwell was just telling us, breathe in, don't forget to do that, and come back on Friday. But this is just to understand the other folks and how to meet them where they're at, okay? You will receive the assignments later today.
Thank you. So everybody, have a great rest of the day.